Surgical critical care. Welcome to today's podcast, where we discuss surgical critical care. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in surgical critical care. Pause the podcast after each question to attempt answer. Let's begin. Introduction question. What is the definition of surgical critical care? Answer. Surgical critical care provides systems-based algorithms for organ support during critical illness, with a specific understanding of surgical pathology and its unique elements of critical illness. Question. How does expertise in surgical critical care benefit patients? Answer. Expertise in surgical critical care allows for earlier recognition and intervention in critically ill or injured surgical patients. Question. What areas are included in the specialization of surgical critical care? Answer. Specialization in surgical critical care includes trauma, cardiac, neurologic, and general surgical areas. Question. How should critical care be delivered? Answer. Critical care is best delivered in a systems-based approach, involving a multidisciplinary team. Question. Who are the members of the multidisciplinary team in surgical critical care? Answer. The multidisciplinary team includes pharmacy, respiratory therapy, nutritional support, advanced practice nursing, social work, and case management. Question. Which specialists should be consulted in surgical critical care? Answer. Specialist consultation is encouraged with specific specialists such as infectious diseases, nephrology, and palliative care. Neurologic system pain. Question. What is the definition of pain? Answer. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Question. What are common sources of pain in the intensive care unit? Answer. Common sources of pain in the intensive care unit include procedures, endotracheal tubes, dressing changes, suctioning, turning, and immobility. Question. What is notable about pain sources in intensive care unit patients? Answer. Intensive care unit patients have multiple sources of pain, some of which are easily recognized while others are often overlooked. Question. How do intensive care unit patients experience pain sensation? Answer. Intensive care unit patients often experience heightened pain sensation, known as hyperalgesia or hypernociception. Question. What causes increased pain sensitivity in intensive care unit patients? Answer. Increased pain sensitivity in intensive care unit patients is caused by pro-inflammatory cytokines, such as interleukin-1 and interleukin-6, which are released after tissue injury. Question. Which intensive care unit patient populations experience heightened pain sensation? Answer. Both surgical and medical intensive care unit patients experience heightened pain sensation. Question. What percentage of intensive care unit patients report inadequate pain treatment? Answer. Up to 50% of intensive care unit patients report inadequate pain treatment. Question. What are the consequences of untreated pain in intensive care unit patients? Answer. Untreated pain can lead to physiological changes such as increased heart rate and metabolic disturbances, respiratory complications like pneumonia, and psychological issues including anxiety and post-traumatic stress disorder. Question. What is the impact of untreated pain on patients' health and well-being? Answer. Untreated pain can have serious short-term and long-term effects on patients' health and well-being. Question. What percentage of intensive care unit patients report inadequate pain treatment? Answer. Up to 50% of intensive care unit patients report inadequate pain treatment. Question. What are the consequences of untreated pain in intensive care unit patients? Answer. Untreated pain can result in physiological changes, respiratory complications, and psychological issues. Question. What is the impact of untreated pain on patients' health and well-being? Answer. Untreated pain can have serious short-term and long-term effects on patients' health and well-being. Question. What challenges exist in pain management for intensive care unit patients? Answer. Intensive care unit patients face difficulties in pain recognition and quantification due to various barriers. Question. What are provider-level barriers to adequate pain management in the intensive care unit? Answer. Provider-level barriers include knowledge gaps about pain's physiological effects, medication options, and the misconception that sedation provides analgesia. Question. What are patient-level barriers to pain management in the intensive care unit? Answer. Patient-level barriers include inability to report pain and fear of being labeled as drug-seeking. Question. Which pain scales are used for verbal patients in the intensive care unit? Answer. The numerical rating scale and the verbal rating scale are used for verbal patients in the intensive care unit. Question. How does the numerical rating scale work for assessing pain? Answer. Patients rate pain on a scale from 0 to 10 or 0 to 100, with 0 representing no pain and the maximum value representing the worst pain imaginable. Question. How does the verbal rating scale assess pain? Answer. Patients describe pain levels using adjectives such as mild, moderate, or severe. Question. What pain assessment tools are used for nonverbal patients in the intensive care unit? Answer. The Wong-Baker Faces Pain Rating Scale, Behavioral Pain Scale, and Critical Care Pain Observation Tool are used for nonverbal patients. Question. What are the limitations of nonverbal pain assessment tools? Answer. Nonverbal pain assessment tools have limited accuracy in patients with dementia, cultural differences, or confounding factors. Question. What is the ideal method of pain assessment in the intensive care unit? Answer. Self-reported pain scales are preferred over behavioral pain scores. Pain control medications. Opioids. Question. What is a narcotic? Answer. A narcotic is a drug that produces sensory depression. Question. What is the origin of opioids? Answer. Opioids are derived from the natural chemical opiate. Question. How do opioids work? Answer. Opioids bind to opioid receptors, including mu, delta, kappa, and others, to produce physiological effects. Question. What are the effects of mu opioid receptor agonists? Answer. Mu opioid receptor agonists produce analgesia and respiratory depression. Question. How do opioids provide analgesia? Answer. Opioids activate descending inhibitory neurons in the midbrain, reducing nociceptive transmission to the thalamus. Question. What are the effects of delta opioid receptor agonists? Answer. Delta opioid receptor agonists produce spinal analgesia and reduced gastric motility. Question. What are the effects of kappa opioid receptor agonists? Answer. Kappa opioid receptor agonists cause diuresis and dysphoria. Question. What are the side effects of opiates? Answer. Opiates can cause depressed consciousness, drowsiness, euphoria, respiratory depression, histamine release, hypotension, and gastrointestinal dysmotility. Question: what factors contribute to the addictive potential of opiates? Answer: euphoria and depressed consciousness contribute to opiates' addictive potential. Question: what are the gastrointestinal effects of opiates? Answer: opiates cause constipation, nausea, and vomiting due to gastrointestinal dysmotility. Question: what are the characteristics of morphine? Answer: morphine has a slow onset of action, undergoes significant first-pass metabolism, and is the standard for comparing other opioids. Question: what are the advantages of fentanyl and remifentanil compared to morphine? Answer: fentanyl and remifentanil have high lipid solubility, leading to rapid onset of action and reduced risk of hypotension compared to morphine. Question: how does tramadol work? Answer: tramadol acts on mu-opioid receptors and also functions as a serotonin norepinephrine reuptake inhibitor. Question: what is opioid-induced hyperalgesia? Answer: opioid-induced hyperalgesia occurs when chronic narcotic use leads to increased pain sensitivity, requiring higher doses for pain relief. Question: what are common medications used to manage opioid use disorder? Answer: methadone and buprenorphine are commonly used to manage opioid use disorder and help curb withdrawal and control cravings. Question: what is required for pain management in intensive care unit patients with chronic opioid use? Answer: pain management requires a multidisciplinary approach to provide adequate pain control and prevent withdrawal in patients with a history of chronic opioid use. Question: how should methadone be managed in intensive care unit patients? Answer: the home methadone dose should be started as soon as possible, and a specialist should be consulted for any dosage changes. Question: how should buprenorphine be managed in intensive care unit patients? Answer: the standard buprenorphine dose, without naloxone, should be continued, and additional analgesics should be used for acute pain. Question: does buprenorphine maintenance therapy hinder pain control in intensive care unit patients? Answer: studies show similar morphine-equivalent opioid requirements with methadone or buprenorphine maintenance therapy, addressing concerns about buprenorphine hindering pain control. Question: when is naloxone used in intensive care unit patients? Answer: naloxone is used for opioid overdose or respiratory depression. Question: what is the mechanism of action of naloxone? Answer: naloxone is a non-selective opioid receptor antagonist that primarily targets mu-opioid receptors. Question: what are the effects and administration methods of naloxone? Answer: naloxone is fast-acting, 2 minutes, when given intravenously or intranasally, but may require repeated doses due to its short half-life. Pain control medications, non-opioids. Question: what are the benefits of multimodal pain therapy? Answer: multimodal pain therapy is essential for adequate pain control and provides opioid-sparing effects. Question: how do nonsteroidal anti-inflammatory drugs work? Answer: nonsteroidal anti-inflammatory drugs inhibit cyclooxygenase enzymes, reducing prostaglandin and thromboxane synthesis. Question: what is the recommended usage for ketorolac? Answer: ketorolac reduces opioid use but should be limited to 5 days due to risks of bleeding and kidney injury. Question: how effective is ketorolac for pain control? Answer: ketorolac provides extremely good pain control and is an important adjunct in multimodal pain protocols. Question: what is the mechanism of action for acetaminophen? Answer: acetaminophen inhibits cyclooxygenase without anti-inflammatory effects and has central effects with multiple proposed mechanisms. Question: what precautions should be taken with acetaminophen use? Answer: caution should be used in patients with liver disease or when used with other drugs containing acetaminophen due to the risk of hepatic failure. Question: how do regional blocks aid in pain management? Answer: long-acting local anesthetic regional blocks can reduce opioid requirements in the first 24 to 72 hours after administration. Question: what are the benefits of using an epidural catheter? Answer: an epidural catheter provides continuous pain relief by infusing local anesthetic, with or without an opioid. Question: what are the limitations of regional blocks for pain control? Answer: regional blocks provide temporary pain control, which wears off with the anesthetic's half-life. Question: what drugs are used for neuropathic pain? Answer: gabapentin and pregabalin are used for neuropathic pain. Question: what is the mechanism of action for gabapentin and pregabalin? Answer: both drugs bind to a subunit of voltage-dependent calcium channels and act as inhibitors. Question: how potent is pregabalin compared to gabapentin? Answer: pregabalin is at least twice as potent as an analgesic compared to gabapentin. Agitation and delirium. Agitation. Question: what is the definition of agitation? Answer: agitation is a psychomotor disturbance marked by heightened motor and psychological activity. Question: what often drives agitation in patients? Answer: agitation is often driven by anxiety. Question: what is the impact of agitation on patient care in the intensive care unit? Answer: agitation can lead to disorganized actions and thoughts, potentially compromising patient care in the intensive care unit. Question: what scales are used to assess consciousness in the intensive care unit? Answer: the Glasgow Coma Scale and the Richmond Agitation Sedation Scale are used to assess consciousness. Question: how is the Glasgow Coma Scale scored? Answer: the Glasgow Coma Scale ranges from 3, completely unresponsive, to 15, normal responsiveness, assessing ocular, verbal, and motor responses. Question: how is the Richmond Agitation Sedation Scale used in the intensive care unit? Answer: the Richmond Agitation Sedation Scale is commonly used in intensive care units to assess sedation and agitation levels. Question: what are non-pharmacologic interventions for agitation in the intensive care unit? Answer: non-pharmacologic interventions include reassurance, comfort, pain control, family visitation, and sleep. Question: when should restraints be considered for patients in the intensive care unit? Answer: restraints should be considered only if a patient is harming themselves or others, and should be reassessed daily due to potential harm. Question: what medications are used for sedation in the intensive care unit? Answer: sedation medications are used in the intensive care unit for patient management. Question: what is the mechanism of action of benzodiazepines? Answer: benzodiazepines enhance the effect of gamma-aminobutyric acid, an inhibitory neurotransmitter, leading to sedation, anxiety reduction, and muscle relaxation. Question: what are the clinical uses of benzodiazepines? Answer: Benzodiazepines are commonly used for alcohol withdrawal, anxiety disorders, seizures, and sedation in intensive care units. Question. What are the primary choices for sedation in the intensive care unit, and what are their risks? Answer. Midazolam and lorazepam are primary choices for sedation, but the risk of delirium and accumulation favors non-benzodiazepines for long-term sedation. Question. What is the usage of propofol in the intensive care unit? Answer. Propofol is a commonly used non-benzodiazepine sedative in intensive care units, administered via boluses or intravenous infusion. Question. What are the effects of propofol? Answer. Propofol potentiates gamma-aminobutyric acid A receptors, causing respiratory depression and hypotension, with rapid awakening upon discontinuation. Question. What are the side effects of propofol? Answer. Side effects include green urine, hypertriglyceridemia, and rare but serious propofol-related infusion syndrome characterized by lactic acidosis, rhabdomyolysis, acute renal failure, and heart failure. Question. What is the classification and effect of dexmedetomidine? Answer. Dexmedetomidine is an alpha-2 receptor agonist that provides sedation, amnesia, and pain relief without causing respiratory depression. Question. How does dexmedetomidine compare to midazolam or propofol for sedation? Answer. Randomized controlled trials have shown that dexmedetomidine is non-inferior to midazolam or propofol for sedation and is associated with a shorter duration of mechanical ventilation. Question. What are the side effects and alternative uses for alpha-2 agonists? Answer. Hypotension and bradycardia are dose-dependent side effects. Clonidine, another alpha-2 agonist, can be used to wean from benzodiazepines or dexmedetomidine. Question. What are the benefits of sedation holidays in intensive care unit patients? Answer. Sedation holidays reduce the duration of mechanical ventilation and intensive care unit length of stay. Question. What is the standard of care for mechanically ventilated patients regarding sedation holidays? Answer. Sedation holidays are the standard of care for mechanically ventilated patients in the intensive care unit. Question. What is the definition of a sedation holiday? Answer. A sedation holiday is an interruption in sedative infusions until patients are awake. Delirium. Question. What is delirium? Answer. Delirium is a disturbance in attention and impaired cognition that develops quickly. Question. What is the prevalence of delirium in mechanically ventilated patients? Answer. Up to 80% of mechanically ventilated patients develop delirium. Question. What tool is reliable for assessing delirium in the intensive care unit? Answer. The confusion assessment method for the intensive care unit is a reliable tool for assessing delirium. Question. Is there strong evidence supporting pharmacologic agents for delirium prevention? Answer. There is limited evidence supporting the use of pharmacologic agents for delirium prevention. Question. Are antipsychotics effective in reducing delirium rates or intensive care unit mortality? Answer. Antipsychotics, whether used prophylactically or for treatment, have not been shown to reduce delirium rates or intensive care unit mortality. Question. What are the only proven preventative measures for delirium? Answer. Non-pharmacologic therapies, such as establishing a sleep-wake cycle and frequent reorientation, are the only proven preventative measures for delirium. Question. How is delirium managed in the intensive care unit? Answer. Delirium management involves both pharmacologic and non-pharmacologic therapies. Question. What non-pharmacologic interventions are used for delirium? Answer. Non-pharmacologic interventions include treating underlying medical conditions, managing pain, using sedation holidays, and providing frequent reorientation. Question. What pharmacologic interventions are used to treat hyperactive delirium? Answer. Antipsychotics, particularly atypical antipsychotics, are used to treat hyperactive delirium and are less likely to cause extrapyramidal symptoms compared to first-generation antipsychotics like haloperidol. Cardiovascular system. Question. What are the main categories of cardiovascular dysfunction? Answer. The main categories of cardiovascular dysfunction are cardiac arrhythmias, cardiogenic shock, and myocardial ischemia. Question. What are the causes of cardiovascular dysfunction? Answer. Cardiovascular dysfunction can be caused by primary cardiac dysfunction, such as heart failure or myocardial infarction, or by extracardiac disease processes, such as pulmonary embolism, hyperthyroidism, or increased metabolic demand. Question. How is the cardiovascular system monitored? Answer. The cardiovascular system is monitored using both invasive and non-invasive methods to assess heart and fluid status. Cardiac physiology. Question. How does the heart function in the circulatory system? Answer. The heart functions as a two-pump circuit that supplies oxygenated blood to the body's tissues. Question. What factors determine oxygen delivery in the body? Answer. Oxygen delivery is determined by cardiac output, hemoglobin concentration, oxygen saturation, and the partial pressure of dissolved oxygen. Question. How does vascular resistance differ between pulmonary and systemic circulations? Answer. The pulmonary vascular bed has significantly lower resistance compared to the systemic vascular bed. Question. What are the primary determinants of the blood's oxygen carrying capacity? Answer. Hemoglobin and oxygen saturation are the primary determinants of the blood's oxygen carrying capacity, while dissolved oxygen plays only a minor role. Question. What does cardiac output represent? Answer. Cardiac output represents the volume of blood pumped by the heart per unit time, typically measured in liters per minute. Question. How is cardiac index calculated? Answer. Cardiac index is calculated by normalizing cardiac output through division by the total body surface area. Question. What is vascular resistance? Answer. Vascular resistance is the resistance of all blood vessels against blood flow. Question. What are the types of vascular resistance? Answer. The types of vascular resistance are systemic vascular resistance and pulmonary vascular resistance. Question. What law governs the relationship between flow, pressure, and resistance in the cardiovascular system? Answer. Ohm's law, which states that the pressure gradient equals flow multiplied by resistance, governs the relationship between flow, pressure, and resistance in the cardiovascular system. Question. What is the functional limitation of the right heart in response to pulmonary vascular resistance? resistance? Answer. The right heart has limited ability to increase its output when there is a sudden increase in pulmonary vascular resistance. Question. What is the impact of a sudden rise in pulmonary vascular resistance, especially with low preload? Answer. A sudden rise in pulmonary vascular resistance, especially when preload is low, can lead to cardiovascular collapse. Question. What clinical scenarios can cause sudden increases in pulmonary vascular resistance leading to right heart failure? Answer. Clinical scenarios such as trauma pneumonectomy and acute pulmonary embolism can cause sudden increases in pulmonary vascular resistance, leading to right heart failure. Question. How is the myocardial blood supply provided? Answer. The myocardial blood supply is primarily provided by the coronary arteries during diastole. Question. When does subendocardial perfusion occur and what is the direction of blood flow during systole? Answer. Subendocardial perfusion occurs during diastole, and during systole, there is retrograde blood flow. Question. What is the implication of full chest recoil during cardiopulmonary resuscitation? Answer. Full chest recoil during cardiopulmonary resuscitation is crucial for subendocardial blood supply. Question. What controls the heart rate? Answer. The sinoatrial node, which is influenced by sympathetic and parasympathetic stimulation, primarily controls the heart rate. Question. What happens if the sinoatrial node fails? Answer. If the sinoatrial node fails, the heart has a series of escape pacemakers, including the atria, atrioventricular node, and ventricles, that take over. Question. How do sympathetic and parasympathetic stimulation affect heart rate? Answer. Sympathetic stimulation, originating from spinal levels T1 to T4, increases heart rate, which is called positive chronotropy, while parasympathetic stimulation from the vagus nerve decreases heart rate, which is called negative chronotropy. Cardiac arrhythmias. Supraventricular tachycardias. Question. What is atrial fibrillation? Answer. Atrial fibrillation is a type of supraventricular tachycardia. Question. How common is postoperative atrial fibrillation after surgery? Answer. Postoperative atrial fibrillation is common, occurring in 8% of major surgeries and 45% of cardiac or thoracic operations. Question. What is the risk of thromboembolism after non-cardiac surgery in patients with atrial fibrillation? Answer. The risk of thromboembolism is similar to those with non-valvular atrial fibrillation after non-cardiac surgery. Question. When should anticoagulation be considered for atrial fibrillation after surgery? Answer. Anticoagulation should be considered based on the CHA2DS2 VASC score if the rhythm persists for more than 48 hours and the surgical bleeding risk is acceptable. Question. How should unstable atrial fibrillation be managed? Answer. Immediate synchronized cardioversion is required for patients with hemodynamically unstable atrial fibrillation. Question. What are the pharmacologic options for stable atrial fibrillation? Answer. Pharmacologic methods include amiodarone, beta blockers, and calcium channel blockers. Question. What should be considered when selecting drugs for atrial fibrillation management? Answer. Amiodarone is preferred in heart failure. Metoprolol has a high success rate for rate control. Diltiazem may cause hypotension, and digoxin is not recommended for acute rate control. Question. When can cardioversion from atrial fibrillation to sinus rhythm be performed safely? Answer. Cardioversion can be performed safely within 48 hours of rhythm onset. Question. What is required for cardioversion after 48 hours of atrial fibrillation? Answer. Cardioversion after 48 hours requires either a transesophageal echocardiogram to rule out clot formation or 4 weeks of anticoagulation, except in acute hemodynamic compromise. Question. What does recent research suggest about the safe period for cardioversion? Answer. Recent research suggests a shorter safe period for cardioversion, potentially as little as 12 hours. Question. What should be considered when using amiodarone for atrial fibrillation? Answer. Amiodarone should be used cautiously in patients with prolonged atrial fibrillation due to its high tendency to induce sinus rhythm. Question. What is the recommended treatment for atrial fibrillation with pre-excitation? Answer. In patients with accessory pathways such as Wolff-Parkinson-White syndrome, Ibutylide or procainamide are recommended, and medications like calcium channel blockers, beta blockers, amiodarone, and digoxin are contraindicated. Question. What should be done if a patient with atrial fibrillation is hemodynamically stable? Answer. If the patient is hemodynamically stable, review electrocardiograms to confirm the rhythm and rule out an accessory pathway. Question. How should chemical cardioversion for atrial fibrillation be approached? Answer. Aggressive attempts at prompt chemical cardioversion should be made using beta blockade and or amiodarone. Question. What should be done if atrial fibrillation rhythm persists? Answer. If the rhythm persists, consider transitioning to a rate control strategy with beta blockers or calcium channel blockers and anticoagulation. Question. What is multifocal atrial tachycardia? Answer. Multifocal atrial tachycardia is another type of supraventricular tachycardia. Question. What is the most common precipitating factor for multifocal atrial tachycardia? Answer. Hypomagnesemia is the most common precipitating factor for multifocal atrial tachycardia. Question. What are other precipitating factors for multifocal atrial tachycardia? Answer. Other precipitating factors include pulmonary insufficiency, hypokalemia, and coronary artery disease. Question. How is multifocal atrial tachycardia treated? Answer. Treatment involves correcting hypomagnesemia and hypokalemia, followed by the use of beta blockers and calcium channel blockers. Question. What is atrial flutter? Answer. Atrial flutter is a type of supraventricular tachycardia. Question. What causes atrial flutter? Answer. Atrial flutter is often caused by the same disorders as atrial fibrillation and can be triggered by amiodarone treatment for atrial fibrillation. Question. What is the prognosis of atrial flutter? Answer. Atrial flutter is an unstable rhythm that can spontaneously transition to atrial fibrillation or normal sinus rhythm. Question. What are the treatment options for atrial flutter? Answer. Treatment options include rate control, rhythm control, and electrocardioversion, with electrocardioversion being preferred. Antiarrhythmic drugs are an option for high-risk patients who cannot undergo sedation for electrocardioversion. Question. Which drug is approved by the Food and Drug Administration for converting atrial flutter to normal sinus rhythm? Answer. Ibutylide is approved by the Food and Drug Administration for converting atrial flutter to normal sinus rhythm. Question. How effective is ibutylide for converting atrial flutter? Answer. Ibutylide is superior to amiodarone and procainamide for converting atrial flutter. Question. What risks are associated with ibutylide and how can they be be mitigated? Answer. Ibutylide carries a risk of torsades de pointes, requiring cautious use, monitoring, and potentially intravenous magnesium. Question. What is atrioventricular nodal reentrant tachycardia? Answer. Atrioventricular nodal reentrant tachycardia is the most common subtype of supraventricular tachycardia and is characterized by a reentrant circuit in the atrioventricular node. Question. How is atrioventricular nodal reentrant tachycardia diagnosed and treated? Answer. Vagal maneuvers can reveal the underlying rhythm, while adenosine, beta blockers, and calcium channel blockers can terminate the tachycardia. Question. Why is it important to distinguish atrioventricular nodal reentrant tachycardia from ventricular tachycardia? Answer. It is important because treatment approaches differ, especially in patients with heart disease. Ventricular tachycardia. Question. What is monomorphic ventricular tachycardia? Answer. Monomorphic ventricular tachycardia is a type of ventricular arrhythmia. Question. What are the treatment options for stable ventricular arrhythmias? Answer. Lidocaine, amiodarone, and procainamide are options for stable patients. Question. Which drug is superior for converting stable ventricular tachycardia? Answer. Procainamide is superior to amiodarone for converting stable ventricular tachycardia. Question. How should unstable ventricular tachycardia be managed? Answer. Unstable ventricular tachycardia requires close monitoring and expeditious treatment due to the risk of sudden deterioration. Question. What is polymorphic ventricular tachycardia? Answer. Polymorphic ventricular tachycardia is a type of ventricular arrhythmia. Question. What is the difference between monomorphic and polymorphic ventricular tachycardia? Answer. Monomorphic ventricular tachycardia arises from a single focus, often ischemic, while polymorphic ventricular tachycardia indicates multiple foci or global dysfunction. Question. What is torsades de pointes? Answer. Torsades de pointes is a polymorphic ventricular tachycardia characterized by a prolonged QT interval, which may be drug-induced or inherited. Question. How is torsades de pointes treated? Answer. Treatment for torsades de pointes includes aggressive magnesium administration and unsynchronized cardioversion if the patient is unstable. Bradycardia. Question. How is bradycardia managed? Answer. Bradycardia is managed with pharmacologic and electrical support, similar to tachyarrhythmias. Question. Is treatment always necessary for bradycardia? Answer. Treatment is not always required if bradycardia is asymptomatic and physiological. Question. What are some causes of acute bradycardia? Answer. Causes include potentially life-threatening conditions such as spinal cord injury, myocardial infarction, hypoxia, toxicity, and sepsis. Question. What is sinus bradycardia? Answer. Sinus bradycardia is a type of bradyarrhythmia. Question. What is the primary treatment for hemodynamically stable sinus bradycardia? Answer. Atropine is the primary treatment for hemodynamically stable sinus bradycardia. Question. How is sinus bradycardia treated in spinal cord injury? Answer. Sinus bradycardia in spinal cord injury is treated with atropine and vasopressors to address neurogenic shock. Question. How is sinus bradycardia in myocardial infarction managed? Answer. Sinus bradycardia in myocardial infarction, particularly in cases of inferior wall infarction, is treated with atropine. Question. How should hypotension be treated in sinus bradycardia? Answer. Hypotension should be treated with vasopressors until the drug wears off. Question. When may pacing be required in sinus bradycardia? Answer. Pacing may be required if hypotension is significant and unresponsive to moderate vasopressor use. Question. Why are atropine and epinephrine ineffective for sinus bradycardia caused by dexmedetomidine? Answer. Atropine and epinephrine are ineffective due to the alpha-1 antagonist effect of dexmedetomidine. Question. What is heart block, junctional, or ventricular bradycardia? Answer. Heart block, junctional, or ventricular bradycardia is caused by profound atrioventricular node dysfunction. Question. What causes heart block, junctional, or ventricular bradycardia? Answer. Profound atrioventricular node dysfunction causes heart block, junctional, or ventricular bradycardia. Question. How are heart block, junctional, or ventricular bradycardia treated? Answer. Temporary pacing may be required if cardiac output falls. Question. Why is atropine ineffective for heart block, junctional, or ventricular bradycardia? Answer. Atropine is ineffective because it acts on the dysfunctional atrioventricular node. Question. Can atrioventricular conduction block cause bradycardia? Answer. Yes. Atrioventricular conduction blocks can cause bradycardia. Question. What are the types of atrioventricular conduction blocks? Answer. Types include first-degree block, which is a delay in conduction, second-degree block, which is intermittent non-conduction, and third-degree block, which is no relationship between atrial and ventricular rhythms. Question. How are atrioventricular conduction blocks treated? Answer. First-degree blocks generally do not require treatment. Third-degree blocks often require pacing, and second-degree block treatment depends on context and hemodynamic stability. Shock. Question. What is the definition of shock? Answer. Shock is a circulatory failure causing end organ dysfunction due to reduced perfusion. Question. What are the indicators of shock? Answer. Indicators of shock include signs of end organ dysfunction, such as rising lactate, altered mental status, falling urine output, and liver enzyme elevation. Question. What are the major categories of shock? Answer. The major categories of shock are distributive, hypovolemic, cardiogenic, and obstructive. Distributive shock. Question. What is neurogenic shock? Answer. Neurogenic shock is a type of shock that occurs after a spinal cord injury, characterized by decreased vascular resistance and hypotension. Question. What are the variants of neurogenic shock based on the location of the spinal cord injury? Answer. The variants are lower spinal cord injuries, below cervical vertebra 5, which result in reflex tachycardia, and higher injuries, cervical vertebra 5 and above, which often cause bradycardia. Question. How is neurogenic shock typically treated? Answer. Neurogenic shock is typically treated with vasopressor support, and norepinephrine is increasingly used, especially in bradycardic patients. Question. What is the difference between neurogenic shock and spinal shock? Answer. Neurogenic shock is a hemodynamic phenomenon, while spinal shock is the temporary loss of reflexes after a spinal cord injury. Question. What are the symptoms of spinal shock? Answer. The symptoms of spinal shock include loss of reflexes, most commonly the bulbocavenosus and cremasteric reflexes. Question. Can neurogenic shock and spinal shock co-present in spinal cord injury? inflammatory? Answer: yes. Neurogenic shock and spinal shock may co-present in spinal cord injury but are distinct phenomena. Question: what is septic shock? Answer: septic shock is a dysregulated immune response to bacterial or fungal pathogens, leading to organ dysfunction. Question: what is the definition of sepsis? Answer: sepsis is organ dysfunction represented by an increase in sequential organ failure assessment score of 2 or more. Question: how is septic shock defined? Answer: septic shock is defined as sepsis with hypotension despite fluid resuscitation and or a serum lactate greater than 2 despite a lack of hypovolemia. Question: what does the quick sequential organ failure assessment measure? Answer: the quick sequential organ failure assessment measures respiratory rate, altered mentation, and low systolic blood pressure. Question: how may the quick sequential organ failure assessment be used? Answer: the quick sequential organ failure assessment may be used similarly to systemic inflammatory response syndrome or other previous criteria. Question: what do the most recent surviving sepsis campaign guidelines recommend regarding the quick sequential organ failure assessment? Answer: the most recent surviving sepsis campaign guidelines recommend against using the quick sequential organ failure assessment over systemic inflammatory response syndrome or other previous criteria. Question: what were the previous sepsis management guidelines? Answer: the previous sepsis management guidelines included immediate lactate measurement, a 2-liter fluid bolus, empiric antibiotic administration, fluid resuscitation titration, and potentially a Swan-Ganz catheter. Question: what is early goal-directed therapy in sepsis management? Answer: early goal-directed therapy is a term used to describe the previous sepsis management guidelines. Question: what have subsequent randomized controlled trials shown about early goal-directed therapy? Answer: subsequent randomized controlled trials suggest limited benefit, potentially because control groups incorporated early goal-directed therapy as standard care. Question: what risk may result from attempting to correct every hemodynamic metric in sepsis? Answer: attempting to correct every hemodynamic metric may lead to over-resuscitation. Question: what principle of early goal-directed therapy remains accepted? Answer: metric-guided hemodynamic resuscitation to goal euvolemia remains accepted, with changes primarily in the hemodynamic measures used to assess volume status. Question: how important is early antibiotic administration in sepsis, and what considerations should be made? Answer: early recognition and administration of antibiotics are crucial for increased survival, but it is essential to consider the risk of antibiotic resistance and unnecessary administration. Question: how does early source control affect outcomes in septic shock? Answer: early source control of the infection is positively linked to better outcomes. Question: what should be the treatment approach for septic shock? Answer: the treatment approach should address both vasodilation and fluid leakage. Question: what is the standard initial treatment for septic shock? Answer: the standard initial treatment is fluid resuscitation, followed by vasopressors if needed. Question: when is vasopressor therapy indicated in septic shock? Answer: vasopressor therapy is used when fluid resuscitation alone does not improve blood pressure. Question: how much crystalloid fluid should be administered in the first 3 hours of septic shock treatment? Answer: 30 milliliters per kilogram of crystalloid fluid should be administered in the first 3 hours. Question: what are the monitoring targets in septic shock? Answer: close monitoring, a target mean arterial pressure of 65 millimeters of mercury, and lactate as a measure of tissue hypoperfusion are recommended. Question: how should fluid responsiveness be assessed in septic shock? Answer: fluid responsiveness should be assessed using dynamic parameters like passive leg raise and fluid challenges instead of central venous pressure. Question: what is the preferred first-line vasopressor in septic shock? Answer: norepinephrine is the preferred vasopressor for treating hypotension when crystalloid fluid resuscitation is ineffective. Question: what vasopressor can be used if norepinephrine is inadequate in septic shock? Answer: epinephrine can be used if norepinephrine is inadequate, especially when cardiogenic shock is suspected. Question: which vasopressor should be avoided as a first-line agent in septic shock? Answer: phenylephrine is not recommended as a first-line agent due to its association with higher in-hospital mortality in septic shock. Question: when should low-dose vasopressin be added in septic shock? Answer: low-dose vasopressin should be added when norepinephrine requirements exceed 5 micrograms per minute to address relative vasopressin deficiency in inflammatory vasodilatory shock. Question: is high-dose vasopressin recommended in septic shock? Answer: high-dose vasopressin is not recommended. Question: when may epinephrine or dobutamine be used in septic shock? Answer: epinephrine may be added if high-dose norepinephrine and vasopressin are insufficient, and dobutamine can be used to improve tissue perfusion if cardiac output is low. Question: what is the current recommendation for corticosteroid use in septic shock? Answer: the current recommendation is to use low-dose steroids in specific cases of vasopressor-dependent, volume-replete septic shock. Question: what is the Surviving Sepsis Campaign recommendation regarding steroid use? Answer: the Surviving Sepsis Campaign recommends low-dose steroids for vasopressor-dependent, volume-replete septic shock. Question: what did the Adrenal study find regarding steroid use in septic shock? Answer: the Adrenal study found no decrease in 90-day mortality, but faster shock resolution and shorter mechanical ventilation duration. Question: what are some other etiologies of distributive shock? Answer: other etiologies of distributive shock include anaphylactic and endocrine shock. Question: what is the first-line treatment for anaphylactic shock? Answer: epinephrine is the first-line treatment for anaphylactic shock. Question: what adjuncts may be used in anaphylactic shock and what are their limitations? Answer: diphenhydramine and steroids may be used, but diphenhydramine does not manage airway symptoms and may cause hypotension, and steroids take several hours to be effective and have never been proven to be of benefit. Question: what are the causes of endocrine shock? Answer: causes of endocrine shock include severe myxedema coma, hypothyroidism, and Addisonian crisis, adrenal insufficiency. Question: how is endocrine shock diagnosed? Answer: diagnosis of endocrine shock relies on medical history and physical examination. Question: how is myxedema coma treated? Answer: myxedema coma is treated with empiric steroids, levothyroxine, and liothyronine, often until Addison's disease is ruled out. Hypovolemic shock. Question: what is hypovolemic shock? Answer: hypovolemic shock is characterized by increased systemic vascular resistance and decreased cardiac output due to decreased preload. Question: what are the symptoms of hypovolemic shock? Answer: symptoms of hypovolemic shock include cold extremity remedies due to vasoconstriction. Question. How is hypovolemic shock treated? Answer. Hypovolemic shock is treated with fluid resuscitation with crystalloid for dehydration or fluid losses. Hemorrhagic shock. Question. What is the preferred resuscitative fluid in hemorrhagic shock? Answer. Blood products are the preferred resuscitative fluid in hemorrhagic shock. Question. What are the two main resuscitation strategies for hemorrhagic shock? Answer. The two main strategies are empiric resuscitation, often using a massive transfusion protocol, or resuscitation guided by clotting analysis such as Thromboelastography or Rotational Thromboelastometry. Question. What is empiric transfusion in hemorrhagic shock? Answer. Empiric transfusion involves administering blood products in a predetermined ratio, often as part of a massive transfusion protocol, until bleeding is controlled or resuscitation goals are met. Question. What is the commonly used component therapy ratio in hemorrhagic shock? Answer. The commonly used ratio is 1:1:1 of plasma to packed red blood cells to platelets. Question. What does recent data suggest regarding whole blood versus component therapy in hemorrhagic shock? Answer. Recent data suggests whole blood may be superior to component therapy in hemorrhagic shock. Question. How can blood transfusion be guided in hemorrhagic shock? Answer. Blood transfusion can be guided by viscoelastic testing, such as Thromboelastography or Rotational Thromboelastometry, which provides dynamic assessment of clotting ability and strength. Question. What are the benefits of viscoelastic testing in hemorrhagic shock? Answer. Viscoelastic testing offers guidance on which blood components or adjuncts, such as fresh frozen plasma, cryoprecipitate, platelets, or tranexamic acid, may be beneficial for managing bleeding. Question. How does thromboelastography function in trauma resuscitation? Answer. Thromboelastography uses vibration of a blood sample and measures clot impedance over time, displaying it graphically. Question. What is the evidence for thromboelastography in trauma resuscitation? Answer. Evidence suggests thromboelastography may be beneficial in trauma resuscitation, particularly when transfusion requirements are high. Question. How do outcomes compare between thromboelastography and empiric massive transfusion protocol? Answer. Outcomes are generally similar between thromboelastography and empiric massive transfusion protocol until a transfusion threshold is reached. Question. What is the Eastern Association for the Surgery of Trauma guideline for thromboelastography? Answer. The Eastern Association for the Surgery of Trauma endorses the use of thromboelastography in trauma, surgical, and intensive care unit patients. Question. Is there evidence for early vasopressor use in hemorrhagic shock? Answer. There is minimal evidence for early use of vasopressors, but they may be a necessary temporizing adjunct during blood product administration. Question. When may vasopressin administration be helpful in hemorrhagic shock? Answer. Specific evidence suggests vasopressin administration may be helpful in a vasopressin deficient state. Cardiogenic shock. Question. What is cardiogenic shock? Answer. Cardiogenic shock is a cold shock characterized by decreased cardiac output due to heart dysfunction, with compensatory vasoconstriction. Question. What is the most common cause of cardiogenic shock and what are some other causes? Answer. The most common cause is coronary artery disease, but other causes include diastolic or systolic heart failure, left or right heart failure, and valvular obstruction. Question. What are the stages of heart failure? Answer. Heart failure progresses through 3 stages: increased filling pressure with preserved contractility, decreased stroke volume with increased heart rate, and finally decreased cardiac output. Question. What is the recommended therapy for right heart failure? Answer. Right heart failure therapy includes fluid boluses for euvolemia, followed by inodulators like dobutamine or milrinone. Question. When are inodulators appropriate in right heart failure therapy? Answer. Inodulators are ideal for low cardiac output and high systemic vascular resistance, but may not be suitable for low blood pressure. Question. How should hypertension be managed in right heart failure? Answer. In right heart failure, vasopressors that increase pulmonary vascular resistance should be avoided. Alternatives like vasopressin may be considered. Question. What is important for managing left heart failure? Answer. Careful assessment of fluid status is crucial for managing left heart failure, as patients can be fluid overloaded, hypovolemic, or euvolemic. Question. How is volume status determined in left heart failure? Answer. Volume status can be determined by assessing weight, pedal edema, and inferior vena cava ultrasound. Question. What emerging tools may aid in managing hemodynamically unstable patients with left heart failure? Answer. Newer non-invasive monitoring tools using arterial waveform analysis may aid in managing hemodynamically unstable patients, though their accuracy is condition-specific. Question. What treatments are recommended for hypertensive heart failure? Answer. Nitroglycerin, nitroprusside, or nicardipine can be used to decrease afterload and improve blood flow. Question. What treatment is used for normotensive heart failure? Answer. Inodulators can be used to improve cardiac output in normotensive heart failure. Question. How should hypotensive heart failure be treated? Answer. Vasodilators can be used cautiously in hypotensive heart failure, ensuring blood pressure is maintained. Question. What treatments are available for low blood pressure and cardiac output in heart failure? Answer. Epinephrine or dopamine infusions may be used, but they can worsen the condition by increasing afterload. Question. What are the options for mechanical circulatory support if pharmacologic measures fail? Answer. Options include intra-aortic balloon pumps, left ventricular assist devices, and veno-arterial extracorporeal membrane oxygenation. Question. What should be done if a facility lacks resources for mechanical circulatory support? Answer. If a facility lacks resources, the patient should be transferred to a center with mechanical circulatory support capabilities. Obstructive shock. Question. What are the etiologies of obstructive shock? Answer. Etiologies of obstructive shock include tension pneumothorax, cardiac tamponade, constrictive pericarditis, and massive pulmonary embolism. Question. How is obstructive shock treated? Answer. Obstructive shock is treated with interventional procedures procedures to remove the cause of obstruction, such as needle decompression, thoracostomy tube, pericardiocentesis, pericardial window, thoracotomy or sternotomy, heparinization, thrombolysis, and thrombectomy. Question: how is obstructive shock diagnosed? Answer: obstructive shock diagnosis requires a high index of suspicion. Myocardial infarction. Question: why are myocardial ischemia and myocardial infarction during the perioperative period considered serious conditions? Answer: myocardial ischemia and myocardial infarction in the perioperative period are serious conditions because they have high rates of illness and death, even when there are no symptoms. Question: what are the different types of myocardial infarction and how are they caused? Answer: type 1 myocardial infarction is caused by the rupture of a plaque and decreased blood flow, while type 2 myocardial infarction results from an imbalance between the supply of oxygen and the demand for oxygen by the heart. Question: how is myocardial infarction treated based on its type? Answer: treatment for type 1 myocardial infarction focuses on restoring blood flow to the heart, while treatment for type 2 myocardial infarction aims to decrease the heart's need for oxygen. Question: what are the main categories of myocardial infarction? Answer: the main categories of myocardial infarction are street segment elevation myocardial infarction and non-street segment elevation myocardial infarction. Question: what are the characteristics of street segment elevation myocardial infarction? Answer: street segment elevation myocardial infarction is characterized by symptoms, increased cardiac enzyme levels, and elevation of the ST segment on an electrocardiogram. Question: what distinguishes non-street segment elevation myocardial infarction from street segment elevation myocardial infarction? Answer: non-street segment elevation myocardial infarction is similar to street segment elevation myocardial infarction, but does not show evidence of infarction on the electrocardiogram. Question: what is the main treatment for type 1 myocardial infarction, and what is an alternative if timely intervention is not possible? Answer: the main treatment for type 1 myocardial infarction is percutaneous coronary intervention, and thrombolysis is used as an alternative if timely intervention cannot be performed. Question: how should non-street segment elevation myocardial infarction be managed, and what factors complicate the decision? Answer: management of non-street segment elevation myocardial infarction may be delayed for up to 72 hours, but the decision is complex due to the risks and benefits associated with the use of anticoagulants. Question: what should be considered when deciding to use anticoagulation in patients with myocardial infarction? Answer: the risks of anticoagulation, such as stroke or bleeding, must be balanced against the benefits, especially in patients who have recently undergone neurosurgical procedures. Question: what complications should be managed in patients with myocardial infarction? Answer: complications that should be managed include shock due to heart problems, high blood pressure, chest pain, and abnormal heart rhythms. Question: what medications are appropriate for administration in myocardial infarction? Answer: appropriate medications include nitroglycerin, intravenous opiates, aspirin, medicines to prevent blood clotting, and medicines that slow the heart rate. Question: why is it important to have immediate access to a defibrillator in cases of myocardial infarction? Answer: immediate access to a defibrillator is important to treat potentially life-threatening abnormal heart rhythms. Respiratory system. Question: what is a common manifestation of critical illness in the respiratory system, and what intervention is often required? Answer: respiratory failure is a frequent manifestation of critical illness, and it often necessitates the use of mechanical ventilation. Question: what causes acute respiratory failure, and how does it affect oxygen levels? Answer: acute respiratory failure is caused by an inflammatory response that leads to alveolar collapse and interstitial edema, resulting in low oxygen levels, also known as hypoxia. Question: what is the main focus of treatment for respiratory failure in critical illness? Answer: the primary focus of treatment is supportive care while minimizing complications associated with positive pressure ventilation. Respiratory physiology. Question: what are the two linked processes in respiratory physiology? Answer: the two linked processes are oxygenation and ventilation. Question: what is oxygenation in the respiratory system? Answer: oxygenation is the process of adding oxygen to the bloodstream from the inspired air. Question: what does ventilation refer to in respiratory physiology? Answer: ventilation refers to the clearance of carbon dioxide from the bloodstream. Question: what do the processes of ventilation and perfusion involve? Answer: both ventilation and perfusion involve the movement of air through the respiratory system and the flow of blood in the pulmonary circulation. Question: what is a ventilation-perfusion mismatch? Answer: a ventilation-perfusion mismatch is an imbalance between air movement, ventilation, and blood flow, perfusion, in the lungs. Question: what are the extremes of ventilation-perfusion mismatch? Answer: the extremes include shunt physiology, where there is blood flow without air movement, and dead space physiology, where there is air movement without blood flow. Question: what is considered a normal ventilation-perfusion mismatch in the lungs? Answer: normally, less than 10% of the cardiac output does not participate in gas exchange, and 20 to 30% of total ventilation does not equilibrate with blood. Question: what conditions can cause an increase in shunt fraction? Answer: an increased shunt fraction can be caused by asthma, alveolar distension such as pulmonary edema or pneumonia, atelectasis, or pulmonary embolism. Question: what causes dead space ventilation in the respiratory system? Answer: dead space ventilation can be caused by destruction of the alveolar capillary interface, low cardiac output, or alveolar overdistension during positive pressure ventilation. Question: what is physiologic dead space in the respiratory tract? Answer: physiologic dead space refers to areas of the respiratory tract, such as the trachea and bronchi, that do not participate in gas exchange. Oxygen therapy. Question: what considerations are necessary regarding the use of oxygen therapy in the intensive care unit? Answer: oxygen is a drug with both risks and benefits, so it requires careful consideration and should only be used when clearly indicated. Question: what fraction of inspired oxygen is recommended for intubated and mechanically ventilated patients? Answer: a target fraction of inspired oxygen of less than 50% is recommended for intubated and mechanically ventilated patients to avoid pulmonary toxicities. Question: at what fraction of inspired oxygen is extubation typically performed, and what is the next step in oxygen delivery? Answer: extubation typically occurs at a fraction of inspired oxygen of 30 to 40%, with a transition to other supplementary oxygen delivery methods afterwards. Non-invasive ventilation ventilation question. What is the purpose of using continuous positive airway pressure and bilevel positive airway pressure as non-invasive ventilatory support? Answer. Continuous positive airway pressure and bilevel positive airway pressure are used to avoid intubation in patients with impending respiratory failure. Question. How do continuous positive airway pressure and bilevel positive airway pressure function to support ventilation? Answer. Continuous positive airway pressure provides continuous pressure, while bilevel positive airway pressure offers different pressures for inhalation and exhalation. Both provide positive and expiratory pressure to keep alveoli open. Question. For which patients is bilevel positive airway pressure especially beneficial? Answer. Bilevel positive airway pressure is particularly beneficial for patients with pulmonary edema from congestive heart failure and those with hypercarbic ventilatory insufficiency. Question. What are the contraindications for using positive pressure ventilation? Answer. Contraindications for positive pressure ventilation include altered mental status, large volume emesis, and fresh esophageal, gastric, or duodenal anastomosis. Question. What risk does positive pressure ventilation pose in the context of emesis? Answer. Positive pressure can lead to aspiration, especially when there is large volume emesis. Question. Why might non-invasive positive pressure ventilation be risky when the lower esophageal sphincter pressure is compromised? Answer. Non-invasive positive pressure ventilation can be risky if the lower esophageal sphincter pressure is compromised, as this may increase the risk of aspiration. High-flow nasal cannula question. What is high-flow nasal cannula and how does it differ from a regular nasal cannula? Answer. High-flow nasal cannula is a non-invasive ventilatory support method that delivers oxygen at higher flow rates than a regular nasal cannula. Question. How does the maximum flow rate compare between high-flow nasal cannula and regular nasal cannula? Answer. High-flow nasal cannula can deliver up to 60 liters per minute of oxygen, whereas a regular nasal cannula can deliver a maximum of about 10 liters per minute. Question. What is the primary benefit associated with the use of high-flow nasal cannula? Answer. The main benefit of high-flow nasal cannula is likely the rapid delivery of oxygen, rather than the provision of significant positive pressure. Question. What were the findings of a 2015 study comparing intubation rates and mortality among high-flow nasal cannula, and non-invasive positive pressure ventilation in hypoxic patients? Answer. A 2015 study found no difference in intubation rates among high-flow nasal cannula, and non-invasive positive pressure ventilation, but high-flow nasal cannula showed favorable results for 90-day mortality. Question. What did a 2016 randomized trial find regarding the rate of reintubation with high-flow nasal cannula compared to conventional nasal cannula after extubation? Answer. The 2016 randomized trial found that high-flow nasal cannula was associated with a lower rate of reintubation within 72 hours compared to conventional nasal cannula. Intubation and mechanical ventilation question. What are the main indications for intubation in clinical practice? Answer. The main indications for intubation are airway protection, hypoxia, and hypercarbia. Question. What are some reasons for airway protection requiring intubation? Answer. Reasons for airway protection include depressed mental status, although the evidence-based practice is debated, and edema resulting from various causes. Question. What are some causes of airway edema that may necessitate intubation? Answer. Causes of airway edema include hereditary angioedema, trauma, severe allergic reactions, or airway burns. Question. What are the main causes of hypoxia that may require intubation? Answer. The main causes of hypoxia requiring intubation include pneumonia, pulmonary contusion, severe pulmonary edema, or acute respiratory distress syndrome. Question. What are some causes of hypercarbia and hypoventilation that can lead to the need for intubation? Answer. Causes include respiratory depression from opioids or sedating medications, exhaustion from increased work of breathing, or spinal cord injury. Question. Why might patients with high spinal cord injury experience delayed ventilatory failure? Answer. Patients with a high spinal cord injury, above the level of the fifth cervical vertebra, may initially compensate with accessory muscles, which can delay the presentation of ventilatory failure. Question. What are the risks associated with intubation, especially in hemodynamically unstable patients? Answer. Intubation, particularly in hemodynamically unstable patients, carries risks such as hemodynamic collapse due to induction agents, hypoxia, and positive pressure ventilation. Question. Why is adequate resuscitation before intubation important? Answer. Adequate resuscitation before intubation is important to reduce the risk of hemodynamic collapse and to better prepare the patient for the procedure. Question. When might vasopressors be required in the context of intubation? Answer. Vasopressors may be needed before and during intubation to manage hemodynamic instability. Standard modes of mechanical ventilation question. How is breath size measured in standard modes of mechanical ventilation? Answer. Breath size is measured as tidal volume in volume-controlled modes or inspiratory pressure in pressure-controlled modes. Question. What determines how often a breath is delivered in mechanical ventilation? Answer. Breath frequency determines how often a breath is delivered, ranging from a completely controlled respiratory rate to patient-triggered breaths. Question. What is positive and expiratory pressure in mechanical ventilation and why is it important? Answer. Positive and expiratory pressure refers to the positive pressure maintained in the lungs at the end of expiration, which is crucial for preventing alveolar collapse. Assist control question. What is assist control mode in mechanical ventilation and how is it achieved? Answer. Assist control mode is a commonly used mode of mechanical ventilation that can be achieved by setting either tidal volume or inspiratory pressure. Question. How does the breathing trigger work in assist control mode? Answer. If the patient is not breathing spontaneously, the set respiratory rate is delivered. If the patient triggers their own breaths, they receive a full breath as set each time. Question. What is tidal volume control in assist control mode? Answer. Tidal volume control is the more common method of setting assist control mode, where the tidal volume is set. Question. How do clinicians select ventilator mode between volume control and pressure control? Answer. Clinicians choose between volume control and pressure control based on the desired control over patient ventilation or pressure. Question. What are the advantages of volume control mode in mechanical ventilation? Answer. Volume control is more common as it allows for better control over minute ventilation, which is crucial for carbon dioxide clearance. Question. What are the advantages of pressure control mode in mechanical ventilation? Answer. Pressure control is preferred in cases of poor compliance to prevent barotrauma by controlling pressure. Question. How is peak pressure measured in mechanical ventilation? ventilation? Answer. Peak pressure is the sum of dynamic airway pressure and alveolar pressure. Question. Why is alveolar pressure significant in mechanical ventilation? Answer. Alveolar pressure is the primary concern as it has the potential for barotrauma. Question. How is plateau pressure measured and what does it indicate? Answer. Measuring plateau pressure by pausing the ventilator at the end of inspiration isolates alveolar pressure and provides a better reflection of lung compliance. Pressure support ventilation. Question. What is pressure support ventilation in mechanical ventilation? Answer. Pressure support ventilation is a mode where patient-triggered breaths are supported by a set pressure and positive and expiratory pressure. Question. How does pressure support ventilation work? Answer. Pressure support ventilation works by allowing patient-triggered breaths that are supported by a set pressure and positive and expiratory pressure. Question. What is the clinical application of pressure support ventilation? Answer. Pressure support ventilation is effective for weaning patients from mechanical ventilation. Synchronized intermittent mandatory ventilation. Question. What is synchronized intermittent mandatory ventilation in mechanical ventilation? Answer. Synchronized intermittent mandatory ventilation is a hybrid mode of mechanical ventilation that combines features of assist control and pressure support ventilation. Question. How does synchronized intermittent mandatory ventilation support spontaneous breaths? Answer. Unlike assist control, synchronized intermittent mandatory ventilation provides a set level of pressure support for spontaneous breaths, allowing patients to generate additional breaths with the applied pressure support. Question. What is the pressure support parameter in synchronized intermittent mandatory ventilation? Answer. A fifth parameter in synchronized intermittent mandatory ventilation, analogous to the inspiratory positive airway pressure setting on bilevel positive airway pressure, determines the level of pressure support for spontaneous breaths. Question. How does synchronized intermittent mandatory ventilation function at different rates? Answer. Synchronized intermittent mandatory ventilation can function similarly to volume control at high rates and pressure support ventilation at low rates, allowing for gradual weaning between the two. Question. What are the benefits of synchronized intermittent mandatory ventilation? Answer. Advocates suggest that the ability to gradually wean between volume control and pressure support ventilation is a key benefit of synchronized intermittent mandatory ventilation. Question. How is the choice between assist control and synchronized intermittent mandatory ventilation made in intensive care units? Answer. The choice between assist control and synchronized intermittent mandatory ventilation as the default ventilation mode in intensive care units often depends on practitioner and unit preferences. Advanced modes of mechanical ventilation. High-frequency oscillatory ventilation. Question. What is high-frequency oscillatory ventilation in mechanical ventilation? Answer. High-frequency oscillatory ventilation is an infrequently used mode of mechanical ventilation that delivers extremely low tidal volumes at a high rate. Question. What is the clinical application of high-frequency oscillatory ventilation? Answer. High-frequency oscillatory ventilation is used as a salvage mode or as a bridge to extracorporeal membrane oxygenation in cases of severe acute respiratory distress syndrome. Question. What is the efficacy of high-frequency oscillatory ventilation in adults and children? Answer. Clinical trials have not demonstrated a benefit for high-frequency oscillatory ventilation in adults, but there are potential benefits in the pediatric population. Airway pressure release ventilation and bilevel positive airway pressure ventilation. Question. For which patients are airway pressure release ventilation and bilevel ventilation used, and what is their purpose? Answer. Airway pressure release ventilation and bilevel ventilation are used for patients with reduced lung compliance, such as those with acute respiratory distress syndrome, to minimize alveolar pressures. Question. What are the characteristics of airway pressure release ventilation? Answer. Airway pressure release ventilation uses a high continuous positive airway pressure for a longer duration and a low continuous positive airway pressure for a shorter duration, making it useful for patients with severe lung noncompliance or a large chest wall. Question. What are the characteristics of bilevel ventilation and how does it differ from airway pressure release ventilation? Answer. Bilevel ventilation is similar to airway pressure release ventilation but with a longer low pressure duration. The high pressure ensures oxygenation, while the low pressure and its duration provide ventilation without derecruitment. Question. What is an alternative to airway pressure release ventilation for achieving similar results? Answer. Adjusting inspiratory and expiratory times in assist control ventilation can achieve results similar to airway pressure release ventilation. Question. How common is airway pressure release ventilation compared to other ventilation modes, and who may benefit from it? Answer. Airway pressure release ventilation is less common than other modes but may be beneficial for certain patients. Question. What benefits does airway pressure release ventilation offer according to meta-analyses? Answer. A meta-analysis suggests that airway pressure release ventilation may provide a mortality benefit for patients with acute hypoxemic respiratory failure compared to conventional ventilation modes. Extracorporeal membrane oxygenation. Question. What is extracorporeal membrane oxygenation used for, and what are its types? Answer. Extracorporeal membrane oxygenation is a treatment for severe respiratory failure and is available in veno-arterial form for cardiac dysfunction and veno-venous form for isolated lung problems. Question. How does the extracorporeal membrane oxygenation process work? Answer. In extracorporeal membrane oxygenation, blood is oxygenated and carbon dioxide is removed in an external oxygenator before the blood is returned to the body. Question. How is blood accessed and returned in extracorporeal membrane oxygenation? Answer. Blood is accessed using cannulas placed in veins or arteries, and the outflow cannula determines where the blood is returned to the body during extracorporeal membrane oxygenation. Question. What is the application of extracorporeal membrane oxygenation in clinical practice? Answer. Extracorporeal membrane oxygenation is used as a bridge therapy, especially for patients in whom recovery is uncertain. Question. For what indication is extracorporeal membrane oxygenation generally accepted, and what evidence supports this? Answer. Extracorporeal membrane oxygenation is generally accepted for use in acute hypoxemic respiratory failure, as suggested by the Caesar trial. Question. Why is the use of extracorporeal membrane oxygenation sometimes controversial? Answer. The use of extracorporeal membrane oxygenation can be controversial, especially in cases where recovery is uncertain. Extubation or tracheostomy. Question. What is the goal when weaning a patient from a ventilator? Answer. The goal is to slowly reduce the amount of support received by the patient while increasing the patient's own respiratory effort. Question. What is a commonly used technique for weaning a patient from the ventilator? Answer. The technique involves transitioning from volume control controlled mode to pressure support mode, then gradually decreasing pressure support. Question: what factors might prevent weaning a patient from a ventilator? Answer: significant hemodynamic instability or other factors may prevent weaning. Question: what is an important criterion for extubation? Answer: airway patency and the ability to protect the airway are important criteria for extubation. Question: what is another criterion for extubation besides airway patency? Answer: sufficient oxygenation and ventilation are also extubation criteria. Question: how is airway patency assessed before extubation? Answer: airway patency is assessed by performing a leak test, which involves deflating the endotracheal tube cuff and observing the loss of ventilated volume. Question: how is the leak test interpreted in the context of extubation? Answer: a loss of 10% to 20% of ventilated volume indicates adequate airway patency, while a smaller loss suggests airway swelling. Question: how is airway swelling typically managed if detected during extubation assessment? Answer: intravenous steroids and reassessment in 24 hours are typically used, and extubation may be considered if the leak persists despite treatment. Question: how is a patient's ability to protect their airway evaluated before extubation? Answer: airway protection is evaluated by the patient's Glasgow Coma Scale score and/or their ability to follow commands. Question: is the inability to follow commands an absolute contraindication for extubation in neurosurgical patients? Answer: the lack of ability to follow commands is not an absolute contraindication for extubation in neurosurgical patients, but decisions require experienced clinicians. Question: what is the best predictor of successful extubation? Answer: the best predictor of successful extubation is the spontaneous breathing trial, which involves minimal pressure support ventilation to assess the patient's ability to breathe spontaneously. Question: what settings are typically used for pressure support ventilation during a spontaneous breathing trial? Answer: minimal pressure support ventilation, typically around 7/15 centimeters of water at 40% inspired oxygen, is used during a spontaneous breathing trial to compensate for the resistance of the endotracheal tube. Question: what is the rapid shallow breathing index and what value predicts successful extubation? Answer: the rapid shallow breathing index is calculated by dividing the respiratory rate by the tidal volume during pressure support ventilation, and a value of less than 105 may indicate a successful extubation. Question: how accurate is the rapid shallow breathing index in predicting successful extubation? Answer: a recent meta-analysis suggests the rapid shallow breathing index has moderate sensitivity and poor specificity. Question: what cutoff values are commonly used for the rapid shallow breathing index? Answer: most studies have used cutoff values below 105. Question: what respiratory mechanics are evaluated to predict successful extubation? Answer: respiratory rate, negative inspiratory force, tidal volume, minute ventilation, and vital capacity are evaluated to predict successful extubation. Question: what is the threshold for negative inspiratory force when considering extubation? Answer: the negative inspiratory force should be more negative than 220 centimeters of water. Question: what is the tidal volume threshold for extubation readiness? Answer: the tidal volume threshold is 0.5 cubic centimeters per kilogram. Question: when should tracheostomy be considered for a patient on mechanical ventilation? Answer: tracheostomy should be considered for patients likely to remain intubated for an extended period. Question: on which day of mechanical ventilation is tracheostomy evaluation commonly performed? Answer: a commonly used day for tracheostomy evaluation is mechanical ventilator day 7. Question: what are the benefits of early tracheostomy in patients requiring prolonged mechanical ventilation? Answer: early tracheostomy is associated with decreased sedation needs, decreased airway risks, and more expedient liberation from the mechanical ventilator. Pulmonary pathology. Pulmonary embolism. Question: what are the mechanisms by which pulmonary emboli affect the lungs? Answer: pulmonary emboli increase pulmonary vascular resistance and cause dead space ventilation. Question: what strategies help prevent pulmonary embolism? Answer: early ambulation, intermittent pneumatic compression devices, and prophylactic anticoagulation are effective prevention strategies. Question: what are the treatment options for pulmonary embolism? Answer: treatment options include supplemental oxygen, systemic anticoagulation, and in severe cases, intubation, thrombolysis, embolectomy, or extracorporeal membrane oxygenation. Pneumonia. Question: how is pneumonia diagnosed? Answer: pneumonia is diagnosed by identifying a new infiltrate on chest radiograph, fever, leukocytosis, and/or purulent secretions. Question: why is pneumonia diagnosis difficult in the intensive care unit? Answer: pneumonia is common in the intensive care unit, which makes clinical diagnosis challenging. Question: what is community-acquired pneumonia? Answer: community-acquired pneumonia is pneumonia contracted outside of a hospital or healthcare setting. Question: what is the recommended treatment for community-acquired pneumonia? Answer: the recommended treatment for community-acquired pneumonia is a beta-lactam combined with a macrolide antibiotic. Question: what diagnostic tests are recommended for patients with severe pneumonia? Answer: sputum culture and blood culture are recommended for patients with severe pneumonia, including those with septic shock and respiratory failure. Question: what should be done for patients empirically treated for methicillin-resistant Staphylococcus aureus or Pseudomonas? Answer: patients empirically treated for methicillin-resistant Staphylococcus aureus or Pseudomonas should have sputum and blood cultures performed. Question: what is ventilator-associated pneumonia? Answer: ventilator-associated pneumonia is pneumonia diagnosed after more than 48 hours of mechanical ventilation. Question: how is ventilator-associated pneumonia defined? Answer: ventilator-associated pneumonia is defined as pneumonia diagnosed after more than 48 hours of mechanical ventilation. Question: is the term hospital-acquired pneumonia still recommended? Answer: the term hospital-acquired pneumonia is no longer recommended. Question: which organizations provide guidelines for pneumonia diagnosis and treatment? Answer: the American Thoracic Society and Infectious Diseases Society of America provide guidelines for pneumonia diagnosis and treatment. Question: what should be done before initiating therapy for ventilator-associated pneumonia? Answer: cultures, such as bronchoalveolar lavage, should be sent before initiating therapy in ventilator-associated pneumonia. Question: who should receive broad-spectrum antibiotics for ventilator-associated pneumonia and for how long? Answer: patients with septic shock, acute respiratory distress syndrome, 5 or more days days hospitalization, and/or renal replacement therapy should receive broad-spectrum antibiotics for 7 days. Question: what is the recommended antibiotic regimen for patients without risk factors for ventilator-associated pneumonia? Answer: patients without risk factors should be treated with a single agent covering Pseudomonas, other gram-negative bacilli, and methicillin-sensitive Staphylococcus aureus. Question: how can ventilator-associated pneumonia be prevented? Answer: elevating the head of the bed to 30 to 45 degrees for all patients can help prevent ventilator-associated pneumonia. Question: what additional prevention measures are recommended for ventilated patients? Answer: daily chlorhexidine rinses and interruptions of sedation are recommended prevention measures for ventilated patients. Question: what is the ultimate prevention strategy for ventilator-associated pneumonia? Answer: early liberation from mechanical ventilation is the ultimate prevention strategy for ventilator-associated pneumonia. Acute respiratory distress syndrome. Question: how is acute respiratory distress syndrome defined? Answer: acute respiratory distress syndrome is an inflammatory lung response to factors such as transfusions, sepsis, pancreatitis, trauma, and hypotension. Question: what are the characteristics of acute respiratory distress syndrome? Answer: acute respiratory distress syndrome is characterized by decreased oxygenation ability and reduced lung compliance. Question: what are the Berlin definition criteria for acute respiratory distress syndrome? Answer: the Berlin definition criteria for acute respiratory distress syndrome include bilateral infiltrates on chest imaging, a PaO2 to FiO2 ratio less than 300, a known clinical insult within 7 days, and non-cardiogenic pulmonary edema. Question: how is the severity of acute respiratory distress syndrome determined by the PaO2 to FiO2 ratio? Answer: a PaO2 to FiO2 ratio less than 300 is considered mild, less than 200 is moderate, and less than 100 is severe. Question: how is non-cardiogenic pulmonary edema assessed in acute respiratory distress syndrome? Answer: non-cardiogenic pulmonary edema is assessed by identifying an explanation for pulmonary edema other than heart failure or fluid overload, using methods such as ultrasound rather than wedge pressure measurement. Question: what are the ventilation goals for patients with acute respiratory distress syndrome? Answer: ventilation goals include tidal volumes of 6 to 8 cubic centimeters per kilogram, arterial oxygen pressure between 55 and 80 millimeters of mercury or oxygen saturation between 88 and 95%, plateau pressure less than or equal to 30 centimeters of water, and pH between 7.30 and 7.45. Question: how is acute respiratory distress syndrome primarily managed? Answer: acute respiratory distress syndrome is primarily managed with mechanical ventilation using specific settings. Question: which parameters are important for managing acute respiratory distress syndrome patients on mechanical ventilation? Answer: tidal volume, oxygenation, plateau pressure, and pH are key parameters for managing patients with acute respiratory distress syndrome on mechanical ventilation. Question: what initial steps support oxygenation in acute respiratory distress syndrome? Answer: diuresis and fluid optimization are initial steps to reduce extrapulmonary edema and support oxygenation. Question: what methods can be used to prevent ventilator asynchrony in acute respiratory distress syndrome? Answer: deep sedation and neuromuscular blockade can be used to prevent ventilator asynchrony in acute respiratory distress syndrome. Question: what are the benefits of prone positioning in acute respiratory distress syndrome? Answer: prone positioning reduces mortality in patients with acute respiratory distress syndrome. Question: what are the risks associated with prone positioning in acute respiratory distress syndrome? Answer: prone positioning in acute respiratory distress syndrome poses risks such as limited access to the patient and potential complications during turning. Question: how should prone positioning be implemented for acute respiratory distress syndrome? Answer: prone positioning should be implemented by experienced personnel, with close coordination among staff, and applied early in acute respiratory distress syndrome treatment. Question: what is the role of extracorporeal membrane oxygenation in acute respiratory distress syndrome? Answer: extracorporeal membrane oxygenation is a last resort for severe acute respiratory distress syndrome, with mixed evidence regarding its effectiveness. Question: how does referral to extracorporeal membrane oxygenation centers impact outcomes for acute respiratory distress syndrome patients? Answer: referral to extracorporeal membrane oxygenation centers, even without receiving extracorporeal membrane oxygenation, may improve outcomes for patients with acute respiratory distress syndrome. Question: why are standardized protocols recommended for extracorporeal membrane oxygenation use? Answer: implementing standardized guidelines and algorithms for extracorporeal membrane oxygenation use is recommended to optimize patient outcomes. Question: which treatments do not reduce mortality in acute respiratory distress syndrome? Answer: steroids, inhaled nitric oxide, inhaled epoprostenol, and high-frequency oscillatory ventilation do not reduce mortality in acute respiratory distress syndrome. Question: do alternative modes of mechanical ventilation and inverse ratio ventilation improve mortality in acute respiratory distress syndrome? Answer: alternative modes of mechanical ventilation and inverse ratio ventilation lack proven mortality benefits in acute respiratory distress syndrome. Question: do treatments that improve hypoxia in acute respiratory distress syndrome also impact mortality? Answer: some treatments improve hypoxia in acute respiratory distress syndrome, but they do not impact mortality. Gastrointestinal system nutritional requirements of the critically ill patient. Question: how do energy requirements change in critically ill patients? Answer: energy requirements are higher than baseline in critically ill patients due to the hypermetabolic state induced by acute stressors. Question: what is the metabolic state of most critically ill patients? Answer: critically ill patients are typically in a catabolic state with increased inflammation, cytokine production, and loss of weight and lean body mass. Question: why do nutritional needs often exceed intake in critically ill patients? Answer: nutritional needs often exceed intake in critically ill patients because of underlying comorbidities, inactivity, and poor oral feeding, which can lead to malnutrition and complications. Question: what is the caloric intake recommendation for critically ill patients according to the American Society for Parenteral and Enteral Nutrition Guidelines from 2021? Answer: the American Society for Parenteral and Enteral Nutrition Guidelines from 2021 recommend 12 to 25 kilocalories per kilogram per day for critically ill patients. Question: how have recommendations for calorie feeding changed for critically ill patients? Answer: recommendations for for calorie feeding in critically ill patients have shifted from higher calorie feeding to lower calorie feeding. Question: Is there evidence of harm associated with lower calorie feeding in critically ill patients? Answer: Recent evidence suggests there is no harm from lower calorie feeding in critically ill patients. Question: What trial supports the recommendation regarding energy-dense versus routine enteral feeding in critically ill patients? Answer: The augmented versus routine approach to giving energy trial supports the recommendation regarding energy-dense versus routine enteral feeding in critically ill patients. Question: Why is protein considered important in the nutrition of critically ill patients? Answer: Protein is vital for wound healing, maintaining lean body mass, and supporting immune function in critically ill patients. Question: How do protein requirements in critically ill patients compare to those for carbohydrates and fats? Answer: Protein requirements are proportionally higher than those for carbohydrates and fats in critically ill patients. Question: Does high protein feeding offer benefits over lower protein supplementation in critically ill patients? Answer: Recent evidence suggests that high protein feeding does not offer benefits over lower protein supplementation in critically ill patients. Question: Should albumin, transferrin, and prealbumin be used as proxies for nutritional status in critically ill patients? Answer: The American Society for Parenteral and Enteral Nutrition recommends against using albumin, transferrin, and prealbumin as proxies for nutritional status in critically ill patients. Question: What happens to serum marker levels such as albumin, transferrin, and prealbumin during significant stress or trauma? Answer: Levels of these serum markers decrease during significant stress or trauma due to increased vascular permeability and reallocation of hepatic protein synthesis. Question: How should serum marker values be interpreted in the context of nutritional assessment? Answer: Serum marker values should be interpreted alongside the patient's hospital course and clinical status. Question: What approach is required for nutritional assessment in critically ill patients? Answer: Nutritional assessment in critically ill patients requires a comprehensive approach, including physical examination, clinical judgment, and ancillary studies. Question: Why is an individualized nutrition plan essential for critically ill patients? Answer: An individualized nutrition plan is essential for providing effective nutritional support to critically ill patients. Question: Can a single test reliably assess a patient's overall nutritional status? Answer: No single test can reliably assess a patient's overall nutritional status. Stress ulcer prophylaxis. Question: How does the gastrointestinal mucosa respond to hemodynamic changes in critically ill patients? Answer: The gastrointestinal mucosa is highly sensitive to hemodynamic changes in critically ill patients. Question: What are the consequences of splanchnic hypoperfusion in critically ill patients? Answer: Splanchnic hypoperfusion can lead to mucosal ischemia, reperfusion injury, and decreased mucosal protection, potentially causing ulcer formation. Question: What complications can result from ulcers in critically ill patients? Answer: Ulcers in critically ill patients can result in bleeding or perforation. Question: How does mechanical ventilation with high positive end expiratory pressure and tidal volumes affect hemodynamics? Answer: High positive end expiratory pressure and tidal volumes during mechanical ventilation can decrease venous return, right heart filling, and cardiac output. Question: How common are gastric ulcerations in trauma patients, and what is their clinical significance? Answer: Gastric ulcerations are common in trauma patients, occurring in up to 90% of cases, but their clinical significance is unclear because only a small percentage lead to significant gastrointestinal bleeding. Question: What are major risk factors for gastrointestinal ulcerations and bleeding in critically ill patients? Answer: Major risk factors for gastrointestinal ulcerations and bleeding in critically ill patients include mechanical ventilation for over 48 hours and coagulopathy. Question: What agents are commonly used for prophylaxis against stress ulcers in critically ill patients? Answer: Gastric acid suppressants such as proton pump inhibitors and histamine 2 receptor blockers, as well as mucosal protective agents, are commonly used for prophylaxis against stress ulcers in critically ill patients. Question: What additional considerations may indicate the need for prophylaxis against gastrointestinal ulcers? Answer: Additional considerations that may indicate the need for prophylaxis include elevated intracranial pressure, burns, high-dose corticosteroid use, chronic or high-dose nonsteroidal anti-inflammatory drug use, and a history of gastric ulceration or gastrointestinal bleeding. Question: What are the main treatment options for stress ulcer prophylaxis and treatment in critically ill patients? Answer: Proton pump inhibitors and histamine 2 receptor antagonists are the main treatment options for stress ulcer prophylaxis and treatment in critically ill patients. Question: What are the potential risks associated with gastric acid suppression in critically ill patients? Answer: Gastric acid suppression can lead to bacterial overgrowth, aspiration pneumonia, and increased survival rates of Clostridium difficile in critically ill patients. Question: Why does gastric acid suppression increase infection risks in the gastrointestinal tract? Answer: Gastric acid suppression increases infection risks because gastric acid is a natural barrier against pathogens. Question: Is there a difference in mortality, hospital length of stay, or Clostridium difficile infection rates between proton pump inhibitors and histamine 2 receptor blockers? Answer: There is no difference in mortality, hospital length of stay, or Clostridium difficile infection rates between proton pump inhibitors and histamine 2 receptor blockers. Question: How do proton pump inhibitors affect the rate of clinically important upper gastrointestinal bleeding in critically ill patients? Answer: Proton pump inhibitors are associated with a lower rate of clinically important upper gastrointestinal bleeding in critically ill patients. Question: What does significant crossover from histamine 2 blockers to proton pump inhibitors indicate in clinical studies? Answer: Significant crossover from histamine 2 blockers to proton pump inhibitors indicates that many patients initially started on histamine 2 blockers are switched to proton pump inhibitors during treatment. Question: Is universal gastrointestinal prophylaxis necessary in all intensive care unit patients? Answer: There is debate on the necessity of near universal gastrointestinal prophylaxis in intensive care units due to improved care and early enteral feeding. Question: Is there strong evidence supporting gastrointestinal prophylaxis outside of patients on mechanical ventilation or those with specific conditions? Answer: There is a lack of strong evidence supporting gastrointestinal prophylaxis outside of patients on mechanical ventilation and those with specific conditions. Question: In which critically ill patients might it be reasonable to restrict gastrointestinal prophylaxis? Answer: It may be reasonable to restrict gastrointestinal prophylaxis to patients with mechanical hyperventilation, coagulopathy, neurotrauma, or new use of steroids or nonsteroidal anti-inflammatory drugs. The open abdomen question. What are the main causes of an open abdomen? Answer. The main causes of an open abdomen are damage control surgery and abdominal compartment syndrome. Question. What is damage control surgery in the management of critically ill patients? Answer. Damage control surgery is a technique used for critically ill patients who require urgent surgery, which involves temporizing injuries and temporarily closing the abdomen. Question. When is definitive repair performed after damage control surgery? Answer. Definitive repair is performed after the patient has been stabilized in the intensive care unit. Question. What is the primary goal in the intensive care unit for patients with an open abdomen? Answer. The primary goal is to correct physiological derangements, including acidosis, hypothermia, and coagulopathy. Question. Who are the typical patients undergoing open abdomen procedures, and how has this changed? Answer. Traditionally, patients undergoing open abdomen procedures were traumatically injured, but increasingly, this approach is also used in emergency general surgery. Question. Are damage control techniques discussed in detail in this section? Answer. No. Damage control techniques are covered in other chapters and are not the focus of this review. Question. How can fluid management impact abdominal closure in open abdomen patients? Answer. Overuse of large volume crystalloid resuscitation can cause bowel edema, which may hinder abdominal closure. Question. What is the potential benefit of hypertonic saline resuscitation in open abdomen patients? Answer. Hypertonic saline resuscitation is theoretically promising for reducing bowel edema, but its benefits may be due to using lower volumes of crystalloid rather than a direct effect on bowel fluid. Question. Why is judicious resuscitation important in intensive care unit patients with an open abdomen? Answer. Judicious resuscitation is beneficial for intensive care unit patients in general and specifically helps with abdominal closure by preventing excessive bowel edema. Question. What is an emerging area of research for resuscitation in open abdomen management? Answer. An emerging research area is direct peritoneal resuscitation. Question. How does direct peritoneal resuscitation work in the context of the open abdomen? Answer. Direct peritoneal resuscitation uses a hypertonic solution to reduce edema and mitigate inflammatory mediators in the bowel. Question. What is the future outlook for direct peritoneal resuscitation in open abdomen management? Answer. Direct peritoneal resuscitation may see increased use in the coming years. Hepatic system cirrhosis question. What is cirrhosis? Answer. Cirrhosis is chronic liver inflammation that replaces normal liver tissue with scar tissue. Question. What are the causes of cirrhosis? Answer. The causes include alcohol-related liver disease, non-alcoholic fatty liver disease, hepatitis B and hepatitis C, and autoimmune diseases. Question. How is cirrhosis diagnosed? Answer. Liver biopsy is the gold standard for diagnosis, while liver elastography and magnetic resonance imaging can assess the severity of fibrosis. Question. What are the physical exam findings in cirrhosis? Answer. Findings include sclerocterus, gynecomastia, loss of secondary sexual characteristics, ascites, spider angiomata, and caput medusae. Question. What laboratory findings are seen in cirrhosis? Answer. Laboratory findings may include low or high transaminases, high bilirubin, hyponatremia, coagulopathy, elevated creatinine, low albumin, anemia, and thrombocytopenia. Question. What is the Child-Turcotte score and how is it used? Answer. The Child-Turcotte score categorizes patients into classes A, B, or C based on albumin, bilirubin, international normalized ratio, ascites, and encephalopathy. Question. Why are ascites and encephalopathy considered subjective measures in cirrhosis scoring? Answer. Ascites and encephalopathy are subjective, which may lead to inconsistency and manipulation of the scoring system. Question. What are the survival rates for cirrhosis according to Child-Turcotte classes? Answer. 1-year survival ranges from 100% in class A to 45% in class C, while postoperative mortality ranges from 10% in class A to 63% in class C. Question. How is the Apache 2 score applied to patients with cirrhosis in the intensive care unit? Answer. The Apache 2 score is used for predicting mortality in intensive care unit patients with cirrhosis. Question. What do studies show about the Apache 2 score in cirrhosis patients? Answer. Several studies support the use of Apache 2 scores for predicting mortality in cirrhosis patients. Question. How is the MELD score applied in cirrhosis? Answer. The MELD score predicts mortality after transjugular intrahepatic portosystemic shunt, determines surgical risk, and aids in listing for transplantation. Question. What are the components of the MELD score? Answer. The MELD score includes objective variables such as international normalized ratio, creatinine, and bilirubin. Question. What is the significance of hyponatremia in cirrhosis patients? Answer. Hyponatremia predicts 3-month waiting list mortality, ascites, and renal dysfunction in cirrhosis patients. Question. What is the new scoring system for cirrhosis and what does it include? Answer. The new scoring system is called MELD-NA, which incorporates sodium levels. Question. What is the purpose of MELD-NA? Answer. MELD-NA is used for transplant organ allocation in cirrhosis patients. Question. Why was the MELD-NA scoring system introduced? Answer. Sodium is an independent predictor of mortality in cirrhosis, which led to the introduction of MELD-NA. Portal hypertension question. How does portal hypertension develop? Answer. Portal hypertension develops due to increased resistance in the portal system caused by changes in hepatic architecture. Question. What happens to nitric oxide production in portal hypertension? Answer. There is decreased production of nitric oxide, a vasodilator, which leads to vasoconstriction in the portal system. Question. What are the consequences of portal hypertension? Answer. Portal hypertension leads to several sequelae of decompensated cirrhosis. Question. What happens to nitric oxide production in the splanchnic circulation? Answer. Nitric oxide production is increased in the splanchnic circulation due to shear stress and bacterial translocation. Question. What is the effect of splanchnic vasodilation? Answer. Splanchnic vasodilation decreases effective circulating blood volume, which leads to hypotension. Question. How does portal hypertension occur? Answer. Portal hypertension occurs due to the combination of splanchnic vasodilation and increased portal flow. Question. What is the design of clinical trials for portal hypertension? Answer. Clinical trials are designed as randomized, double-blind, placebo-controlled trials. Question. Who are the patients included in clinical trials for portal hypertension? Answer. Patients with clinically significant significant portal hypertension are included in these trials. Question: what is the effect of beta blocker treatment in portal hypertension? Answer: beta blocker treatment decreases the risk of decompensation, especially ascites, compared to placebo. Question: which beta blocker is superior in treating clinically significant portal hypertension? Answer: carvedilol outperforms propranolol in treating clinically significant portal hypertension. Question: what is the guideline for the use of beta blockers in portal hypertension? Answer: carvedilol is the preferred beta blocker for preventing decompensation in clinically significant portal hypertension. Question: what is the mechanism of action of beta blockers in portal hypertension? Answer: beta blockers decrease cardiac output by blocking beta-1 receptors and cause splanchnic vasoconstriction by blocking beta-2 receptors. Question: what additional effect does carvedilol have in portal hypertension? Answer: carvedilol also blocks alpha-1 receptors, which reduces the hepatic venous pressure gradient. Ascites. Question: what is ascites? Answer: ascites is the accumulation of fluid in the peritoneal space. Question: what causes ascites? Answer: ascites is caused by a decrease in systemic effective circulating volume, which leads to sodium and water retention. Question: what is the role of the renin-angiotensin-aldosterone system in ascites? Answer: the renin-angiotensin-aldosterone system stimulation promotes sodium and water retention, increasing plasma volume. Question: how is ascites graded? Answer: ascites is categorized into 3 grades: mild, grade 1, moderate, grade 2, and severe, grade 3. Question: how does ascites form? Answer: portal hypertension and splanchnic vasodilation lead to fluid retention in the splanchnic system, increasing hydrostatic pressure and causing fluid to move into the peritoneal space. Question: how is ascites detected at different grades? Answer: grade 1 ascites is detected by ultrasound, grade 2 involves abdominal distension, and grade 3 presents a tense abdomen with a fluid wave. Question: how is the serum ascites albumin gradient calculated? Answer: the serum ascites albumin gradient is calculated by subtracting the ascites albumin concentration from the serum albumin concentration. Question: how is the serum ascites albumin gradient interpreted? Answer: a serum ascites albumin gradient of 1.1 grams per deciliter suggests portal hypertension as the cause of ascites. Question: how does the serum ascites albumin gradient help determine the cause of ascites? Answer: when the cause of ascites is unclear, the serum ascites albumin gradient helps determine the underlying etiology. Question: what is the treatment goal for ascites caused by portal hypertension? Answer: the treatment goal is to treat portal hypertension-induced ascites. Question: what are the methods used to treat ascites? Answer: treatment methods include a low-salt diet, sodium restriction, and diuretics. Question: which diuretics are commonly used in treating ascites? Answer: furosemide and spironolactone are commonly used diuretics. Question: how does furosemide work in the treatment of ascites? Answer: furosemide decreases sodium reabsorption in the thick ascending limb of the loop of Henle. Question: how does spironolactone work in the treatment of ascites? Answer: spironolactone targets aldosterone's role in the pathway leading to ascites formation. Question: what is the treatment for grade 3 ascites? Answer: treatment for grade 3 ascites consists of large volume paracentesis followed by volume expansion with 25% albumin. Question: what is the purpose of volume expansion after paracentesis? Answer: volume expansion is performed to prevent post-paracentesis circulatory dysfunction, which can lead to renal failure and increased mortality. Question: how much volume expansion should be administered after paracentesis? Answer: 6 to 8 grams per liter of fluid removed should be administered for every liter of fluid removed during paracentesis. Spontaneous bacterial peritonitis. Question: what is spontaneous bacterial peritonitis? Answer: spontaneous bacterial peritonitis is an infection of the peritoneal fluid. Question: what is the main cause of spontaneous bacterial peritonitis? Answer: the main cause of spontaneous bacterial peritonitis is increased bacterial translocation due to extra fluid in the peritoneal cavity. Question: what are the clinical signs of spontaneous bacterial peritonitis? Answer: the clinical signs of spontaneous bacterial peritonitis include nonspecific signs of infection, potentially including abdominal pain and gastrointestinal symptoms. Question: how is spontaneous bacterial peritonitis diagnosed? Answer: spontaneous bacterial peritonitis is diagnosed by ascites fluid analysis. Question: what is the diagnostic criterion for spontaneous bacterial peritonitis? Answer: the diagnostic criterion for spontaneous bacterial peritonitis is an ascites fluid neutrophil count of 250 cells per milliliter. Question: what is the initial treatment for spontaneous bacterial peritonitis? Answer: the initial treatment for spontaneous bacterial peritonitis includes supportive measures and intravenous antibiotics. Question: how is antibiotic selection determined for spontaneous bacterial peritonitis? Answer: antibiotic selection for spontaneous bacterial peritonitis is based on institutional resistance patterns, ensuring broad spectrum coverage. Question: what are the indications for prophylaxis against spontaneous bacterial peritonitis? Answer: indications for prophylaxis against spontaneous bacterial peritonitis include active gastrointestinal bleeding, prior history of spontaneous bacterial peritonitis, which may require lifelong prophylaxis, or ascites fluid protein concentration exceeding 1.5 grams per deciliter. Question: what medications are typically used for prophylaxis against spontaneous bacterial peritonitis? Answer: medications typically used for prophylaxis against spontaneous bacterial peritonitis include ciprofloxacin or trimethoprim sulfamethoxazole. Varices. Question: what causes variceal hemorrhage? Answer: variceal hemorrhage is caused by portal pressures exceeding 12 millimeters of mercury, which leads to the formation of varices and potential rupture. Question: what is the initial therapy for variceal bleeding? Answer: the initial therapy for variceal bleeding is to restore plasma volume, administer antibiotics, and use a somatostatin analog. Question: where are varices typically found? Answer: varices are typically found in the stomach and esophagus. Question: what is the treatment goal for varices? Answer: the treatment goal for varices is to stop the hemorrhage. Question: what is a temporary measure for variceal hemorrhage control? Answer: a temporary measure for variceal hemorrhage control is balloon tamponade with a Senstock and Blakemore tube. Question: what is the effect of somatostatin analogs in treating varices? Answer: somatostatin analogs cause splanchnic vasoconstriction, Question. Decrease portal inflow and reduce the risk of continued hemorrhage. Question. How is the gastric balloon inserted for variceal hemorrhage management? Answer. The gastric balloon is inserted through the mouth or nares, inflated with air, and positioned below the diaphragm. Question. When is the esophageal balloon inflated and what are the risks? Answer. The esophageal balloon is inflated for continued bleeding, but it poses a risk of esophageal ischemia and perforation. Question. What are the definitive treatments for variceal hemorrhage? Answer. Definitive treatments for variceal hemorrhage are esophageal band ligation or sclerotherapy, with transjugular intrahepatic portosystemic shunt reserved for refractory cases or portal vein thrombus. Transjugular intrahepatic portosystemic shunt. Question. What are the indications for the transjugular intrahepatic portosystemic shunt procedure? Answer. The indications for the transjugular intrahepatic portosystemic shunt procedure are refractory ascites or recurrent variceal bleeding. Question. How is the transjugular intrahepatic portosystemic shunt procedure performed? Answer. The procedure is performed by deploying a stent to connect the portal and hepatic or systemic systems, shunting blood away from the portal circulation. Question. What is the access point for the transjugular intrahepatic portosystemic shunt procedure? Answer. The access point for the procedure is the right internal jugular vein. Question. What are the contraindications for the transjugular intrahepatic portosystemic shunt procedure? Answer. Contraindications include heart failure and advanced liver disease with a model for end-stage liver disease score of 18. Question. What are the benefits of the transjugular intrahepatic portosystemic shunt procedure? Answer. The benefits include decreased mortality in patients with severe bleeding, ascites, and hepatorenal syndrome. Question. What are the risks associated with the transjugular intrahepatic portosystemic shunt procedure? Answer. There is up to a 20% risk of new or worsened hepatic encephalopathy. Question. Does hepatic encephalopathy risk occur with all portosystemic shunts? Answer. Yes. The risk of hepatic encephalopathy is present in all portosystemic shunts. Question. What causes hepatic encephalopathy after portosystemic shunt placement? Answer. Hepatic encephalopathy after portosystemic shunt placement is caused by ammonia from the bowel bypassing liver metabolism and entering the systemic circulation. Hepatic encephalopathy. Question. What is the definition of hepatic encephalopathy? Answer. Hepatic encephalopathy is a potentially reversible neuropsychiatric disorder. Question. What causes hepatic encephalopathy? Answer. It is caused by hepatic dysfunction and or portal shunting. Question. Why is ammonia considered toxic in the context of hepatic encephalopathy? Answer. Ammonia, a byproduct of protein degradation, is toxic to the brain. Question. What role does the liver play in relation to ammonia in hepatic encephalopathy? Answer. The liver converts ammonia to urea, preventing its accumulation in the blood. Question. How does ammonia lead to brain damage in hepatic encephalopathy? Answer. Ammonia crosses the blood-brain barrier, leading to cellular swelling, damage, and impaired synaptic transmission. Question. What are the clinical features of hepatic encephalopathy? Answer. The clinical features include lethargy, disorientation, asterixis, depressed consciousness, and stupor. Question. How is hepatic encephalopathy graded? Answer. Hepatic encephalopathy is graded from 0, no encephalopathy, to 4, coma. Question. What is the prevalence of grade 2 or higher hepatic encephalopathy in patients with cirrhosis? Answer. Grade 2 or higher hepatic encephalopathy occurs in up to 40% of patients with cirrhosis. Question. What is the primary treatment goal for hepatic encephalopathy? Answer. The treatment goal is to reduce ammonia production in the bowel to prevent its accumulation. Question. How does lactulose work in treating hepatic encephalopathy? Answer. Lactulose acidifies the bowel, eradicating bacteria that convert protein to ammonia and decreasing ammonia absorption. Question. What is the action of lactulose in the body during hepatic encephalopathy treatment? Answer. Lactulose is a non-absorbable disaccharide broken down by Lactobacillus acidophilus. Question. What is the recommended dosage approach for lactulose in hepatic encephalopathy? Answer. The dosage is adjusted to achieve 2 to 3 bowel movements per day. Question. What is the role of rifaximin in hepatic encephalopathy management? Answer. Rifaximin is used as an adjunct to lactulose for encephalopathy prophylaxis. Question. When is prophylaxis for hepatic encephalopathy recommended? Answer. Prophylaxis is recommended after an episode of overt hepatic encephalopathy. Hepatorenal syndrome. Question. What is the definition of hepatorenal syndrome? Answer. Hepatorenal syndrome is a form of renal failure that occurs in patients with cirrhosis and is often triggered by sepsis or inflammation. Question. What is the mechanism by which hepatorenal syndrome develops? Answer. Splanchnic vasodilation and reduced cardiac output cause renal arterial vasoconstriction, leading to a decreased glomerular filtration rate. Question. What role do pro-inflammatory cytokines play in hepatorenal syndrome? Answer. Pro-inflammatory cytokines may contribute to hepatorenal syndrome by causing microvascular dysfunction in the renal tubules, increasing renin-angiotensin-aldosterone system activity, and further decreasing glomerular filtration rate. Question. What are the diagnostic criteria for hepatorenal syndrome? Answer. The diagnosis of hepatorenal syndrome is made when there is renal dysfunction in a patient with cirrhosis that cannot be explained by other causes and does not respond to withdrawal of diuretics or expansion of blood volume. Question. What are the typical urine study findings in hepatorenal syndrome? Answer. Urine studies usually show a sodium concentration less than 10 millimoles per liter and urine osmolality higher than plasma osmolality. Question. How is hepatorenal syndrome classified? Answer. Hepatorenal syndrome is categorized into hepatorenal syndrome acute kidney injury and hepatorenal syndrome non-acute kidney injury. Question. What characterizes hepatorenal syndrome acute kidney injury? Answer. Hepatorenal syndrome acute kidney injury is marked by rapid deterioration of renal function within 1 to 2 weeks. Question. What characterizes hepatorenal syndrome non-acute kidney injury? Answer. Hepatorenal syndrome non-acute kidney injury presents as gradual renal dysfunction that is resistant to diuretics and is associated with refractory ascites. Question. How is hepatorenal syndrome managed? Answer. Management involves the use of a vasopressin analog such as terlipressin to increase renal perfusion pressure, along with a volume expander like albumin. Question. What is the recommended usage of terlipressin for hepatorenal syndrome acute kidney injury? Answer. Terlipressin is recently approved in the United States as first-line therapy for hepatorenal syndrome acute kidney injury and is continued for up to 14 days after creatinine levels return to normal. Question. What was the design of the recent study evaluating treatments for hepatorenal syndrome? Answer. The study was conducted as a multi-center, randomized, placebo-controlled, double-blind trial. Question. How were the treatments compared in patients with hepatorenal syndrome acute kidney injury? Answer. Terlipressin combined with albumin was compared to placebo in patients with hepatorenal syndrome acute kidney injury. Question. What were the key findings from the study on terlipressin in hepatorenal syndrome? Answer. The study found an increased rate of reversal of hepatorenal syndrome with terlipressin, but also noted a risk of respiratory failure. Portopulmonary hypertension, hepatopulmonary syndrome. Question. What is portopulmonary hypertension and how is it characterized? Answer. Portopulmonary hypertension is a condition characterized by elevated pulmonary artery pressures in individuals who have portal hypertension. Question. How is portopulmonary hypertension diagnosed? Answer. Portopulmonary hypertension is diagnosed by measuring pulmonary artery pressures and excluding left-sided heart failure as the underlying cause. Question. How is the severity of portopulmonary hypertension determined? Answer. The severity of portopulmonary hypertension is categorized as mild, moderate, or severe based on the mean pulmonary artery pressure. Question. What is the main cause of portopulmonary hypertension? Answer. The main cause of portopulmonary hypertension is pulmonary vascular vasoconstriction. Question. What is the underlying mechanism of portopulmonary hypertension? Answer. The mechanism involves increased endothelin-1 and decreased prostacyclin levels. Question. Where does endothelin-1 originate in patients with portopulmonary hypertension? Answer. Endothelin-1 originates from the cirrhotic liver in affected patients. Question. What are the treatment options for portopulmonary hypertension? Answer. Treatment options include endothelin receptor antagonists, phosphodiesterase type 5 inhibitors, and prostacyclin analogs. Question. Why is severe portopulmonary hypertension considered an absolute contraindication to liver transplant? Answer. Severe portopulmonary hypertension, defined as a mean pulmonary artery pressure of 45 mm of mercury or above, is an absolute contraindication to liver transplant due to extremely poor postoperative outcomes. Question. Which patients are eligible for model for end-stage liver disease exception points? Answer. Patients with moderate portopulmonary hypertension are eligible for model for end-stage liver disease exception points. Question. What is the purpose of model for end-stage liver disease exception points in patients with portopulmonary hypertension? Answer. The purpose is to prevent patients from experiencing poor postoperative outcomes in liver transplant. Question. Can pulmonary hypertension medications be discontinued after liver transplant in patients with portopulmonary hypertension? Answer. Up to 60% of patients who receive pre- and postoperative therapy can discontinue pulmonary hypertension medications after liver transplant. Question. How does the one-year mortality rate compare between patients with portopulmonary hypertension and model for end-stage liver disease exceptions and those without portopulmonary hypertension after liver transplant? Answer. Patients with pre-transplant portopulmonary hypertension and model for end-stage liver disease exceptions have a higher one-year mortality rate after liver transplant compared to patients without portopulmonary hypertension. Renal anatomy and physiology. Question. What are the primary functions of the kidney? Answer. The kidney maintains homeostasis and metabolizes toxins. Question. How much blood supply do the kidneys receive relative to their body weight? Answer. The kidneys receive 25% of cardiac output despite comprising less than 0.5% of body weight. Question. Where are the kidneys located and what are their main structural components? Answer. The kidneys are located in Birotis fascia and consist of the fibrous capsule, renal cortex, and renal medulla, which includes renal pyramids and papilla, leading to the minor and major calyx, renal pelvis, and ureter. Question. What is the nephron and what are its components? Answer. The nephron is the functional unit of the kidney and comprises the glomerulus and renal tubules, which span the cortex and medulla. Question. How is renal blood flow regulated? Answer. Renal blood flow is autoregulated by the afferent and efferent arterioles, which maintain stable glomerular filtration despite fluctuations in arterial pressure. Question. How do oxygen levels differ between the renal cortex and medulla? Answer. The cortex has higher oxygen levels, with partial pressure of oxygen around 50 mm of mercury to support glomerular filtration, while the medulla has lower oxygen levels, with partial pressure of oxygen around 10 to 20 mm of mercury to preserve osmotic gradients. Question. What factors determine the glomerular filtration rate? Answer. The glomerular filtration rate is determined by blood flow, pressure gradients, surface area, and membrane permeability. Question. How is the glomerular filtration rate regulated? Answer. The glomerular filtration rate is controlled by the constriction or dilation of the afferent and efferent arterioles, and is influenced by hormones such as angiotensin and prostaglandins. Question. What occurs when renal perfusion pressure falls with respect to the renin-angiotensin system? Answer. When renal perfusion pressure falls, renin is released, leading to the production of angiotensin II, which causes vasoconstriction of the efferent arteriole and increases glomerular hydrostatic pressure to maintain glomerular filtration rate. Question. What is reabsorbed by the proximal tubule? Answer. The proximal tubule reabsorbs almost all glucose and amino acids and about 65% of sodium and water. Question. What are the functions of the descending and thick ascending limbs of the loop of Henle? Answer. The descending limb reabsorbs water, while the thick ascending limb reabsorbs sodium and chloride. Question. How is the osmotic gradient in the kidney created? Answer. The thick ascending limb creates the osmotic gradient, which drives water reabsorption in the descending loop. Question. What is the countercurrent multiplier mechanism and how does it affect solute and water reabsorption? Answer. The countercurrent multiplier mechanism increases solute concentration in the medulla, which drives water reabsorption from the descending limb and leads to further solute reabsorption from the thick ascending limb. Question. What is the maximum osmotic gradient achieved in the kidney medulla? Answer. The corticomedullary osmotic gradient reaches a maximum of 1,200 milliosmoles per liter in the deepest regions of the medulla. Question. What is the function of the distal tubule and collecting duct, and how is water permeability regulated? Answer. The distal tubule and collecting collecting duct reabsorb ions and are permeable to water only in the presence of antidiuretic hormone. Question. How does antidiuretic hormone affect the collecting tubule? Answer. Antidiuretic hormone triggers the insertion of aquaporin channels into the apical membrane of the collecting tubule. Question. What is the role of aquaporin channels in the kidney? Answer. Aquaporin channels facilitate water reabsorption down its osmotic gradient. Acid-base regulation. Question. How is body pH regulated? Answer. The respiratory and renal systems tightly regulate body pH. Question. What is the major buffer system in the body? Answer. The carbonic acid bicarbonate buffer system is the major buffer system in the body. Question. How does the carbonic acid bicarbonate buffer system work? Answer. Carbon dioxide reacts with water to form carbonic acid, which then dissociates into bicarbonate and hydrogen ions. Question. How does the respiratory system regulate pH? Answer. The respiratory system adjusts pH by controlling carbon dioxide levels, impacting pH within hours. Question. How does the renal system regulate pH? Answer. The renal system modulates pH by reabsorbing bicarbonate and excreting hydrogen ions or ammonium, influencing pH over days. Question. Where is most of the filtered bicarbonate reabsorbed in the kidney? Answer. Almost all filtered bicarbonate is reabsorbed in the proximal tubule. Question. What does pH represent in the blood? Answer. pH represents the concentration of hydrogen ions in the blood. Question. How are acid-base systems evaluated in the body? Answer. Both metabolic and respiratory systems are evaluated to assess acid-base status. Question. How does the body compensate for acid-base imbalances? Answer. The body compensates for acid-base imbalances by adjusting the other system to normalize pH. Question. How is the primary acid-base disorder determined? Answer. The primary disorder is determined by analyzing blood gas values, including pH, partial pressure of carbon dioxide, and bicarbonate. Question. What indicates a primary respiratory acid-base disorder? Answer. If partial pressure of carbon dioxide and pH change in opposite directions, it indicates a primary respiratory disorder. Question. What indicates a primary metabolic acid-base disorder? Answer. If pH and bicarbonate change in the same direction, it indicates a primary metabolic disorder. Question. What is the normal range of pH in the blood? Answer. The normal pH range in the blood is 7.35 to 7.45. Question. What is the normal range of partial pressure of carbon dioxide? Answer. The normal partial pressure of carbon dioxide range is 35 to 45 millimeters of mercury. Question. What is the normal range for bicarbonate in the blood? Answer. The normal range for bicarbonate in the blood is 22 to 26 milliequivalents per liter. Question. Why are equations used in acid-base disorders? Answer. These equations are used to calculate the expected compensatory response in acid-base disorders. Question. How can mixed acid-base disorders be identified? Answer. Comparing the expected compensatory response with the measured value helps identify mixed acid-base disorders. Question. What does a difference between expected and measured value suggest in acid-base analysis? Answer. A difference between expected and measured value suggests a mixed acid-base disorder involving both systems. Respiratory acidosis. Question. What causes respiratory acidosis? Answer. Hypoventilation leading to increased partial pressure of carbon dioxide causes respiratory acidosis. Question. How does the body compensate for respiratory acidosis? Answer. The kidneys increase bicarbonate reabsorption to compensate for respiratory acidosis. Question. How is compensation for respiratory acidosis calculated? Answer. In acute cases, bicarbonate equals partial pressure of carbon dioxide multiplied by 0.1. In chronic cases, bicarbonate equals partial pressure of carbon dioxide multiplied by 0.4. Respiratory alkalosis. Question. What is respiratory alkalosis? Answer. Respiratory alkalosis is a condition characterized by increased minute ventilation, resulting in decreased carbon dioxide levels. Question. How does the body compensate for respiratory alkalosis? Answer. The body compensates for respiratory alkalosis by adjusting bicarbonate levels. Question. How is compensation for respiratory alkalosis calculated? Answer. In acute cases, bicarbonate equals partial pressure of carbon dioxide multiplied by 0.2. In chronic cases, bicarbonate equals partial pressure of carbon dioxide multiplied by 0.4. Metabolic acidosis. Question. What is metabolic acidosis? Answer. Metabolic acidosis is a condition characterized by a primary reduction in bicarbonate concentration. Question. What are the causes of metabolic acidosis? Answer. Metabolic acidosis can be caused by the addition of acid, loss of bicarbonate, or dilution of bicarbonate by non-bicarbonate fluid. Question. What are the types of metabolic acidosis? Answer. Anion gap metabolic acidosis occurs when an additional acid is buffered by bicarbonate, while non-anion gap metabolic acidosis occurs when bicarbonate is lost or diluted. Question. What is the normal range for the anion gap? Answer. The normal anion gap is between 3 and 11. Question. What does an elevated anion gap indicate in metabolic acidosis? Answer. An anion gap higher than normal, with causes often remembered by the mnemonic mud piles, indicates anion gap metabolic acidosis. Question. What does the mud piles mnemonic stand for in anion gap metabolic acidosis? Answer. Mud piles stands for methanol, uremia, diabetic ketoacidosis, paracetamol, isoniazid, lactic acidosis, ethanol or ethylene glycol, and salicylates. Question. What is the purpose of calculating the delta gap? Answer. The delta gap is used to determine if two metabolic acid-base disorders are present. Question. What is the formula for calculating the delta gap? Answer. The delta gap is calculated as normal anion gap, calculated anion gap, minus normal bicarbonate, calculated bicarbonate. Question. How is the delta gap interpreted? Answer. A significantly positive delta gap suggests metabolic alkalosis, while a significantly negative delta gap indicates non-anion gap metabolic acidosis. Question. What is a limitation of the delta gap method? Answer. The delta gap method oversimplifies the complex buffering system in the body and assumes bicarbonate is the sole buffer. Question. What are some other buffering systems in the body? Answer. Phosphate, hemoglobin, and other plasma proteins also contribute to the body's buffering capacity. Question. What are causes of non-anion gap metabolic acidosis? Answer. Causes include diarrhea, normal saline infusion, and renal tubular acidosis. Question. How does the respiratory system respond to metabolic acidosis? acidosis? Answer. The respiratory system decreases partial pressure of carbon dioxide by increasing minute ventilation. Question. What is the expected change in partial pressure of carbon dioxide in metabolic acidosis? Answer. The expected partial pressure of carbon dioxide is calculated as 1.2 times the bicarbonate concentration. Question. How does acidosis initially affect myocardial function? Answer. Initial decreases in pH are tolerable and can help with oxygen unloading from hemoglobin. Question. What are the effects of worsening acidosis? Answer. With worsening acidosis, myocardial contractility is impaired and the response to catecholamines diminishes. Metabolic alkalosis. Question. What is metabolic alkalosis? Answer. Metabolic alkalosis is an increase in bicarbonate concentration in the plasma. Question. What are the causes of metabolic alkalosis? Answer. Causes include loss of hydrogen ions, addition of bicarbonate, or loss of fluid with low bicarbonate concentration. Question. What is contraction alkalosis and how does it develop? Answer. Contraction alkalosis occurs when loss of plasma volume activates the renin-angiotensin-aldosterone system, leading to increased bicarbonate reabsorption and hydrogen ion excretion. Question. What is the relationship between partial pressure of carbon dioxide and bicarbonate in metabolic alkalosis? Answer. Partial pressure of carbon dioxide increases by 0.7 millimeters of mercury for every 1 millimole per liter increase in bicarbonate. Question. What is the formula to calculate expected partial pressure of carbon dioxide in metabolic alkalosis? Answer. The formula is partial pressure of carbon dioxide equals 0.7 times the bicarbonate concentration. Acute kidney injury. Question. How is acute kidney injury defined? Answer. Acute kidney injury is defined as an increase in serum creatinine of greater than or equal to 3 milligrams per deciliter over 48 hours, an increase in creatinine of greater than or equal to 1.5 times baseline over 7 days, or a urine output of less than 0.5 cubic centimeters per kilogram per hour over 6 hours. Question. How many stages are there in acute kidney injury? Answer. Acute kidney injury is categorized into 3 stages. Question. What characterizes stage 1 of acute kidney injury? Answer. Stage 1 of acute kidney injury is defined by a serum creatinine of 1.5 to 1.9 times baseline. Question. What defines stage 2 of acute kidney injury? Answer. Stage 2 of acute kidney injury is defined by a serum creatinine of 2.0 to 2.9 times baseline. Question. What are the criteria for stage 3 acute kidney injury? Answer. Stage 3 acute kidney injury is defined by a serum creatinine of 3 times baseline or the initiation of renal replacement therapy. Question. What are the Kidney Disease Improving Global Outcomes Guidelines for the prevention of acute kidney injury? Answer. The Kidney Disease Improving Global Outcomes Guidelines recommend preventing acute kidney injury by ensuring adequate volume resuscitation using crystalloids, avoiding hypoglycemia, and avoiding nephrotoxic agents. Question. What should be done for patients at high risk for contrast-induced nephropathy? Answer. For patients at high risk for contrast-induced nephropathy, intravenous fluids should be administered with contrast agents. Question. When is renal replacement therapy indicated in acute kidney injury? Answer. Renal replacement therapy is indicated for toxin removal or when acute kidney injury is associated with severe complications such as hyperkalemia, acidosis, or fluid overload. Question. What are the options for the timing of renal replacement therapy in acute kidney injury? Answer. Renal replacement therapy can be initiated early or at the standard time according to clinical criteria. Question. What is the impact of early renal replacement therapy initiation in acute kidney injury? Answer. Early initiation of renal replacement therapy results in no difference in mortality but leads to a higher dependence on dialysis and an increased number of adverse events. Question. What study design was used to investigate renal replacement therapy timing in acute kidney injury? Answer. A multinational, randomized controlled trial was conducted in intensive care unit patients with acute kidney injury. Question. How were patients compared in studies of renal replacement therapy timing in acute kidney injury? Answer. Patients who received renal replacement therapy within hours were compared to those who received therapy when standard clinical criteria were met. Renal replacement therapy. Question. What are the different methods of renal replacement therapy? Answer. Hemodialysis, which can be performed continuously or intermittently, and peritoneal dialysis are the main methods of renal replacement therapy. Question. How does hemodialysis remove waste from the blood? Answer. Hemodialysis filters blood through a semi-permeable membrane to remove fluid and solutes. Question. In which patients is continuous renal replacement therapy indicated? Answer. Continuous renal replacement therapy is indicated in patients who cannot tolerate large hemodynamic changes. Question. How does ultrafiltration remove fluid during renal replacement therapy? Answer. Ultrafiltration removes fluid by using pressure gradients to move fluid across a membrane. Question. What are the mechanisms for solute removal in renal replacement therapy? Answer. Convection removes solutes by dragging them with fluid flow, while diffusion removes solutes down their concentration gradients. Question. What is required for diffusion to occur during dialysis? Answer. Diffusion requires a dialysate on the opposite side of the membrane to establish a concentration gradient. Question. What is slow continuous ultrafiltration and how does it work? Answer. Slow continuous ultrafiltration removes fluid from patients at a slow blood flow rate, which minimizes solute drag. Question. How does continuous veno-venous hemofiltration remove solutes and fluid? Answer. Continuous veno-venous hemofiltration removes fluid and solutes at a higher blood flow rate, using convection to clear solutes of various sizes. Question. Why is replacement fluid necessary in continuous veno-venous hemofiltration? Answer. Replacement fluid is essential to replenish the patient's fluid balance due to significant fluid removal during solute clearance. Question. Where can replacement fluid be administered during continuous veno-venous hemofiltration? Answer. Replacement fluid may be administered pre-filter, post-filter, or as a combination of both. Question. What are the effects of pre-filter placement of replacement fluid in continuous veno-venous hemofiltration? Answer. Pre-filter placement of replacement fluid dilutes the blood, decreases clearance, but reduces the risk of filter clotting. Question. What are the effects of post-filter placement of replacement fluid in continuous veno-venous hemofiltration? Answer. Post-filter placement improves clearance but increases the risk of filter clotting. Question. How does continuous veno-venous hemodialysis clear solutes? Answer. Continuous veno-venous hemodialysis clears solutes using diffusion by adding dialysate around the semi-permeable membrane. Question. What determines solute clearance during continuous veno-venous hemodialysis? Answer. Solute clearance is determined by the concentration gradient of solutes in the dialysate. Question. What is continuous veno-venous hemodiafiltration? Answer. Continuous veno-venous hemodiafiltration combines elements of both continuous veno-venous hemodialysis and continuous veno-venous hemofiltration. Question. What is intermittent hemodialysis? Answer. Intermittent hemodialysis is a type of renal replacement therapy in which treatment sessions are performed at intervals rather than continuously. Question. What is the mechanism of solute and fluid removal in intermittent hemodialysis? Answer. Intermittent hemodialysis uses dialysis and diffusion for solute removal and can also remove fluid. Question. How do blood flow rates in intermittent hemodialysis compare to continuous renal replacement therapy? Answer. Blood flow rates are much higher over a shorter period of time in intermittent hemodialysis compared to continuous renal replacement therapy, which may cause hemodynamic fluctuations. Hematologic system transfusion strategies. Question. What are common causes of anemia in the surgical intensive care unit? Answer. Anemia in the surgical intensive care unit is common and can be caused by chronic disease, frequent blood draws, trauma, or gastrointestinal bleeding. Question. What transfusion strategy is supported by evidence in the intensive care unit? Answer. Evidence supports a restrictive transfusion strategy, aiming for a hemoglobin level of 7 grams per deciliter. Question. Are higher hemoglobin goals recommended for patients with gastrointestinal bleeding or traumatic brain injury? Answer. Higher hemoglobin goals are not supported for gastrointestinal bleeding or traumatic brain injury. Question. What is the recommended hemoglobin goal for patients with stable cardiovascular disease? Answer. A hemoglobin goal of 8 grams per deciliter may be appropriate for individuals with stable cardiovascular disease. Question. What are some risks associated with blood transfusion? Answer. Transfusion complications can include allergic reactions, fluid overload, iron overload, infections, lung injury, immunosuppression, hypersensitivity reactions, and hemolysis. Question. Is hemoglobin a reliable early indicator of active bleeding? Answer. Declining hemoglobin is a late sign of active bleeding. Question. What should guide transfusion decisions in trauma patients? Answer. In trauma patients, transfusion decisions should be based on clinical parameters like tachycardia, hypotension, and lactate levels, rather than solely on hemoglobin levels. Question. What is a crucial priority in the management of active bleeding? Answer. Prioritizing intervention to achieve hemostasis is crucial in managing active bleeding. Question. How should blood components be administered during transfusion, and when should whole blood be considered? Answer. Component therapy should be balanced, and whole blood should be considered if available. Question. What test may be beneficial in massive transfusion scenarios? Answer. Thromboelastography may be beneficial in massive transfusion. Viscoelastic testing. Question. What is viscoelastic testing and when was it first devised? Answer. Viscoelastic testing is a method to assess the clotting capability of whole blood, initially devised in the 1950s. Question. Why was viscoelastic testing not widely used initially? Answer. Limited accessibility and complexity hindered its widespread use, leading to the preference for conventional coagulation tests. Question. When did viscoelastic testing become more practical and what was its impact? Answer. Viscoelastic testing became more practical and reproducible in the 1980s, leading to its use in guiding resuscitation during surgeries and reducing blood product administration and mortality. Question. What are the advantages of viscoelastic testing? Answer. Viscoelastic testing offers a real-time, detailed functional assay providing information about clot formation, propagation, strength, and lysis. Question. In which patient population are thromboelastography and rotational thromboelastometry increasingly used? Answer. Thromboelastography and rotational thromboelastometry are increasingly used in bleeding patients. Question. How does traditional thromboelastography measure clot formation? Answer. Traditional thromboelastography measures torque of a pin oscillating in patient blood to assess clot formation. Question. What mechanism does the TEG6S device use to measure clot formation? Answer. The TEG6S device utilizes blood sample vibration and a light detector to measure meniscus motion during clot formation. Question. What are the key values measured in a thromboelastogram? Answer. Key values measured include clot formation, clot propagation, clot strength, and thrombolysis. Question. How did rotational thromboelastometry originate? Answer. Rotational thromboelastometry evolved from thromboelastography technology with slightly different parameters and reagents. Question. What does rotational thromboelastometry evaluate? Answer. Rotational thromboelastometry evaluates various aspects of coagulation. Question. In which clinical scenarios is thromboelastography particularly useful? Answer. Thromboelastography is useful in trauma patients, particularly those with massive exsanguination, and after hemorrhage control in the intensive care unit. Question. What do the 2020 Eastern Association for the Surgery of Trauma guidelines say about the use of viscoelastic testing? Answer. The 2020 Eastern Association for the Surgery of Trauma guidelines conditionally recommend its use in specific patient groups. Question. Which patient groups should be considered for viscoelastic testing according to the guidelines? Answer. Bleeding trauma, surgical, and intensive care unit patients with suspected coagulopathy should be considered for viscoelastic testing. Question. What is the strength of the recommendation for viscoelastic testing in these patients? Answer. The recommendation is conditional. Heparin-induced thrombocytopenia. Question. What is heparin-induced thrombocytopenia? Answer. Heparin-induced thrombocytopenia is a life-threatening complication that develops in 1% to 5% of patients who receive heparin therapy. Question. How does heparin-induced thrombocytopenia occur? Answer. Heparin-induced thrombocytopenia occurs when the patient's immune system produces antibodies against the complex formed between heparin and platelet factor 4, resulting in the consumption of platelets. Question. What is the result of the immune response in heparin-induced thrombocytopenia? Answer. The reticuloendothelial system removes these immune complexes, which leads to a decrease in platelet count, known as thrombocytopenia. Question. How is heparin-induced thrombocytopenia diagnosed? Answer. Heparin-induced thrombocytopenia is diagnosed based on clinical features consistent with the condition and recent exposure to heparin. Question. What what is the 4T scoring system for heparin-induced thrombocytopenia? Answer. The 4T scoring system is a clinical tool used to assess the likelihood of heparin-induced thrombocytopenia, evaluating thrombocytopenia, timing of platelet count reduction, thrombosis, and the presence of other causes of low platelet count. Question. How severe is the thrombocytopenia in heparin-induced thrombocytopenia? Answer. Thrombocytopenia in heparin-induced thrombocytopenia generally involves a 50% reduction in platelet count, although decreases between 30% and 50% can also be seen. Question. When does heparin-induced thrombocytopenia typically develop? Answer. Heparin-induced thrombocytopenia usually develops 5 to 10 days after the initiation of heparin therapy, but may occur sooner in patients who have been exposed to heparin previously. Question. How common are thrombotic events in heparin-induced thrombocytopenia? Answer. Thrombotic events are common, occurring in approximately 25% to 68% of patients with heparin-induced thrombocytopenia, and such events can sometimes precede the development of thrombocytopenia. Question. What should be done if the probability of heparin-induced thrombocytopenia is low? Answer. If the probability of heparin-induced thrombocytopenia is low, heparin therapy should be continued and alternative causes of thrombocytopenia should be investigated. Question. What is the management for intermediate or high risk of heparin-induced thrombocytopenia? Answer. For patients with an intermediate or high risk of heparin-induced thrombocytopenia, all forms of heparin should be discontinued. Alternative anticoagulation such as direct thrombin inhibitor should be initiated, and further confirmatory testing should be performed. Question. What is the initial test for heparin-induced thrombocytopenia? Answer. The initial test for heparin-induced thrombocytopenia is the enzyme-linked immunosorbent assay, which detects antibodies against the heparin platelet factor 4 complex. Question. What is the confirmatory test for heparin-induced thrombocytopenia? Answer. The gold standard confirmatory test for heparin-induced thrombocytopenia is the serotonin release assay. Question. How specific is the enzyme-linked immunosorbent assay for heparin-induced thrombocytopenia? Answer. The enzyme-linked immunosorbent assay is sensitive but not specific for heparin-induced thrombocytopenia. Question. How common is heparin-induced thrombocytopenia in intensive care unit patients? Answer. Heparin-induced thrombocytopenia is rare among intensive care unit patients, with an incidence ranging from 0.02% to 0.45%, even though more than 40% of these patients experience thrombocytopenia from other causes. Question. What is the mortality rate of heparin-induced thrombocytopenia? Answer. The mortality rate for heparin-induced thrombocytopenia is between 14.5% and 25%, even with appropriate treatment. Question. What is the recommended management for suspected heparin-induced thrombocytopenia? Answer. All heparin products should be avoided until a definitive diagnosis is established in any patient with suspected heparin-induced thrombocytopenia. Venous thromboembolism. Question. Why are critically ill patients at high risk for venous thromboembolism? Answer. Critically ill patients are at high risk for venous thromboembolism because they frequently experience endothelial injury, venous stasis, and hypercoagulability. Question. How common and diagnosable is venous thromboembolism as a cause of death? Answer. Venous thromboembolism is a common cause of death, but it is often undiagnosed and clinically silent. Question. Is venous thromboembolism a preventable cause of death? Answer. Venous thromboembolism is a preventable cause of death. Question. What is recommended for venous thromboembolism prevention in intensive care unit patients? Answer. All intensive care unit patients should be evaluated and treated to prevent the development of venous thromboembolism. Question. Which guidelines are referenced for venous thromboembolism prevention? Answer. The American College of Chest Physicians Evidence-Based Clinical Practice Guidelines are referenced for venous thromboembolism prevention. Question. Why is thromboprophylaxis sometimes delayed in patients? Answer. Thromboprophylaxis is sometimes delayed because physicians perceive that the risk of bleeding outweighs the risk of venous thromboembolism. Question. What happens if thromboprophylaxis is initiated more than 24 hours after intensive care unit admission following major trauma? Answer. There is a threefold increase in venous thromboembolism formation if thromboprophylaxis is started more than 24 hours after intensive care unit admission following major trauma. Question. What are the absolute contraindications to thromboprophylaxis? Answer. Absolute contraindications to thromboprophylaxis include active bleeding, intracranial hemorrhage, coagulopathy, and severe thrombocytopenia. Question. What are relative contraindications to thromboprophylaxis? Answer. Relative contraindications to thromboprophylaxis include recent gastrointestinal bleeding, recent surgery, and moderate thrombocytopenia. Question. How should decisions about chemical thromboprophylaxis be made in the presence of relative contraindications? Answer. For relative contraindications, the decision to begin chemical thromboprophylaxis should be made on an individual basis. Question. What are the methods used for thromboprophylaxis? Answer. Thromboprophylaxis can be achieved through mechanical means, such as intermittent pneumatic compression devices, and through chemical thromboprophylaxis. Question. How effective is chemical thromboprophylaxis compared to mechanical compression for preventing deep vein thrombosis and pulmonary embolism? Answer. Chemical thromboprophylaxis is proven to be more effective than mechanical compression for the prevention of deep vein thrombosis and pulmonary embolism. Question. What are the benefits of mechanical compression in thromboprophylaxis? Answer. Mechanical compression promotes venous blood flow and activates tissue plasminogen and local fibrinolysis. Question. What is the impact of early chemoprophylaxis in patients with traumatic brain injury? Answer. Early chemoprophylaxis, started between 24 to 72 hours, is generally associated with fewer thromboembolic events and does not increase neurosurgical interventions or mortality, even in patients with mild traumatic brain injury. Question. What is the risk of early chemoprophylaxis in patients with traumatic brain injury who require neurosurgical intervention? Answer. Early chemoprophylaxis in patients who require neurosurgical intervention for traumatic brain injury may increase the risk risk of needing repeat neurosurgical procedures. Question. Who should be involved in decisions regarding chemoprophylaxis in traumatic brain injury patients? Answer. Decisions regarding chemoprophylaxis in traumatic brain injury patients should involve a multidisciplinary team, including trauma surgeons and neurosurgeons. Question. How effective is low molecular weight heparin compared to unfractionated heparin for the prevention of deep vein thrombosis? Answer. Low molecular weight heparin is more effective than unfractionated heparin for preventing deep vein thrombosis, but it is eliminated by the kidneys. Question. What factors increase the risk of failure of venous thromboembolism prophylaxis? Answer. Obesity and pro-inflammatory conditions, such as sepsis, increase the risk of venous thromboembolism prophylaxis failure even when chemical thromboprophylaxis is used. Question. What treatments are effective for patients at increased risk of venous thromboembolism prophylaxis failure? Answer. Goal-directed therapy and titration of low molecular weight heparin dosing based on anti-ZA levels are effective for patients at increased risk of venous thromboembolism prophylaxis failure. Question. How does the availability of anti-ZA assays impact trauma patients? Answer. The increasing availability of anti-ZA assays makes it easier to achieve target levels in trauma patients. Question. What is an alternative treatment for patients who cannot receive chemical thromboprophylaxis for an extended period? Answer. Placement of an inferior vena cava filter is an option for patients who cannot receive chemical thromboprophylaxis for a prolonged period. Endocrine system glucose control. Question. What is stress hyperglycemia? Answer. Stress hyperglycemia is hyperglycemia and insulin resistance occurring in the setting of acute illness. Question. How prevalent is stress hyperglycemia among patients in intensive care units? Answer. Stress hyperglycemia occurs in up to 50% of patients in intensive care units. Question. What causes hyperglycemia in critically ill patients? Answer. Hyperglycemia is caused by an increase in catecholamines and cortisol, which leads to increased gluconeogenesis in the liver. Question. What role do inflammatory cytokines play in stress hyperglycemia? Answer. Inflammatory cytokines contribute to insulin resistance, further worsening hyperglycemia. Question. How does hyperglycemia affect patients in small and large amounts? Answer. Hyperglycemia is protective in small amounts but is harmful when excessive. Question. What are the beneficial effects of hyperglycemia? Answer. Hyperglycemia increases cell plasticity and resistance to ischemia. Question. What detrimental effects are associated with elevated or chronic glucose levels? Answer. Elevated or chronic glucose levels increase morbidity and mortality. Question. What is the goal of glycemic control in critically ill patients? Answer. The goal is to prevent severe hyperglycemia, hypoglycemia, and large glucose fluctuations. Question. What glucose level should be targeted in critically ill patients? Answer. A glucose level of less than 180 mg per deciliter should be targeted. Question. What finding did the NICE sugar study reveal about glucose control? Answer. The NICE sugar study found that more liberal glucose control, targeting less than 180 mg per deciliter, resulted in lower mortality compared to tight control of 81 to 108 mg per deciliter, due to higher incidence of hypoglycemia in the latter group. Question. What is considered the next frontier in glucose control for critically ill patients? Answer. Continuous glucose monitors are considered the next frontier in glucose control. Question. How do continuous glucose monitors impact glycemic control? Answer. Continuous glucose monitors decrease hypoglycemia but do not improve overall glycemic control. Question. What is the current status of continuous glucose monitors in hospitals? Answer. Continuous glucose monitors are approved for emergency use and are increasingly being implemented in hospitals. Critical illness adrenal insufficiency. Question. How is the stress response controlled in the human body? Answer. The hypothalamic pituitary adrenal axis controls the stress response. Question. What is the role of the hypothalamus in the stress response? Answer. The hypothalamus senses stress and releases corticotropin-releasing hormone. Question. How does hormone release occur in response to stress? Answer. Corticotropin-releasing hormone stimulates the anterior pituitary to release adrenocorticotropic hormone, which then stimulates cortisol secretion in the adrenal cortex. Question. When does cortisol peak in healthy individuals? Answer. Cortisol peaks in the early morning and gradually decreases throughout the day. Question. How is cortisol production regulated? Answer. Cortisol exerts negative feedback on the hypothalamus and pituitary gland to regulate its own production. Question. How does critical illness affect cortisol regulation? Answer. Critical illness disrupts cortisol's circadian rhythm, reduces its production and availability, and increases tissue resistance to its effects. Question. What is the definition of critical illness-related corticosteroid insufficiency? Answer. Critical illness-related corticosteroid insufficiency is a relative impairment of the hypothalamic pituitary axis during critical illness. Question. When are stress dose steroids recommended for patients? Answer. Guidelines recommend starting stress dose steroids in patients with septic shock who are unresponsive to fluids and require moderate to high doses of vasopressors. Question. What are the recommendations for steroid treatment in patients on chronic steroids? Answer. Patients on chronic steroids for hypothalamic pituitary adrenal axis related conditions should receive stress doses, while those on steroids for other reasons should receive their home dose and may receive stress doses at the provider's discretion. Question. What is the recommended steroid treatment regimen for critical illness related adrenal insufficiency? Answer. A long and low dose course of intravenous hydrocortisone, 400 mg per day for 3 days, is recommended. Question. How effective is steroid treatment in critical illness related adrenal insufficiency? Answer. Studies show mixed results regarding mortality impact but suggest steroid treatment may shorten shock duration. Question. How is adrenal insufficiency tested in critically ill patients? Answer. Guidelines recommend testing for adrenal insufficiency using a high-dose adrenocorticotropic hormone stimulation test, although this is not commonly practiced. Thyroid dysfunction question. What is the function of thyroid-stimulating hormone? Answer. Thyroid-stimulating hormone stimulates the thyroid gland to produce thyroxine, which is converted to triiodothyronine. Question. How do thyroid hormones regulate thyroid-stimulating hormone secretion? Answer. Thyroid hormones provide negative feedback that suppresses thyroid-stimulating hormone secretion. Question. Why are thyroid-stimulating hormone levels considered the most reliable method for checking thyroid function, and when might they be inaccurate? Answer. Thyroid-stimulating hormone levels are the most reliable method for assessing thyroid function, but they can be unreliable during acute illness. Question. What is hyperthyroidism and what are its primary and secondary causes? Answer. Hyperthyroidism is the presence of excess circulating thyroid hormones, which may be due to overactivity of the thyroid gland or dysfunction of the hypothalamic pituitary adrenal axis. Question. What is thyroid storm and what are its main clinical features? Answer. Thyroid storm is a rare and severe form of hyperthyroidism with a high mortality rate, and is characterized by high fever, agitation or delirium, rapid heart rate, and high output heart failure. Question. How is thyroid storm treated? Answer. Thyroid storm is treated with beta blockers such as propranolol to control rapid heart rate and agitation, and with antithyroid medications such as methimazole or propylthiouracil. Question. How common is hypothyroidism in critically ill patients? Answer. Hypothyroidism is a rare occurrence in critically ill patients. Question. What are the causes of hypothyroidism in critically ill patients? Answer. The causes of hypothyroidism in critically ill patients include autoimmune thyroiditis, dysfunction of the hypothalamic pituitary adrenal axis, and certain medications. Question. What are the symptoms and complications associated with hypothyroidism? Answer. Symptoms and complications of hypothyroidism include fatigue, muscle cramps, constipation, an increased risk of pericardial or pleural effusion, and myxedema coma, which is hypothyroidism with depressed mental status. Infectious diseases general principles question. What proportion of patients in the intensive care unit develop hospital-acquired infections? Answer. 50 to 60% of patients in the intensive care unit develop hospital-acquired infections. Question. What is the impact of hospital-acquired infections on mortality and hospital costs in intensive care unit patients? Answer. Hospital-acquired infections in intensive care unit patients have a mortality rate of up to 35% and account for almost half of hospital costs. Question. What are the most common sites and routes of hospital-acquired infections in intensive care unit patients? Answer. The most common routes and locations of hospital-acquired infections in intensive care unit patients are pulmonary, abdominal, genitourinary, and bloodstream sites. Question. Which organisms are most commonly responsible for hospital-acquired infections in intensive care unit patients? Answer. The most common organisms are gram-positive bacteria such as Staphylococcus aureus and gram-negative bacteria such as Pseudomonas aeruginosa and Escherichia coli. Question. What are the main risk factors for developing hospital-acquired infections in the intensive care unit? Answer. The main risk factors are prolonged stay in the intensive care unit and severe medical comorbidities. Sepsis question. What is the definition of sepsis? Answer. Sepsis is an infection with organ dysfunction due to an unregulated immune and inflammatory response. Question. How is sepsis diagnosed? Answer. Sepsis is diagnosed by the presence of infection and a sequential organ failure assessment score change of 2 points. Question. What is the definition of septic shock? Answer. Septic shock is characterized by low blood pressure despite fluid resuscitation and the need for vasopressors. Question. What type of dysfunction is involved in septic shock? Answer. Septic shock involves cardiovascular dysfunction. Question. What does the pathophysiology of sepsis involve? Answer. The pathophysiology of sepsis involves activation of both pro-inflammatory and anti-inflammatory cytokines and mediators. Question. How is the immune response in sepsis characterized? Answer. The immune response in sepsis is characterized by an overwhelming pro-inflammatory and immunosuppressive response. Question. What complication is often seen during and after recovery from sepsis? Answer. There is an increased risk of hospital-acquired infections during and after recovery from sepsis. Question. What are the causes of shock in sepsis? Answer. Shock in sepsis is caused by alterations in microcirculation, leaky capillaries, and vasodilation. Question. What is the oxygenation imbalance in sepsis? Answer. There is a mismatch between increased tissue oxygen needs and decreased oxygen delivery in sepsis. Question. What type of shock is commonly seen in sepsis? Answer. Distributive shock, which is a combination of the above factors, is commonly seen in sepsis. Question. What challenges exist for identifying sepsis in the intensive care unit? Answer. Traditional sepsis indicators may be masked or altered by existing comorbidities and treatments in intensive care unit patients. Question. Why is early recognition of sepsis important? Answer. Early identification of sepsis is crucial because of its high mortality rate. Question. Why can symptoms of sepsis be misleading in intensive care unit patients? Answer. Intensive care unit patients may present with symptoms such as respiratory failure, altered mental status, and lactic acidosis due to various reasons, which makes the diagnosis of sepsis challenging. Question. What is the recommended resuscitation strategy for sepsis? Answer. 30 cubic centimeters per kilogram of balanced crystalloid solution is recommended, with a focus on dynamic measures. Question. When should antimicrobial therapy be administered in sepsis? Answer. Antimicrobial therapy should be administered within 1 hour of recognizing sepsis. Question. When should vasopressors be initiated in the treatment of sepsis, and which agents are preferred? Answer. Vasopressors should be started early, with norepinephrine as the first-line agent, followed by vasopressin. Nosocomial infections. Ventilator-associated pneumonia. Question. What is the definition of ventilator-associated pneumonia? Answer. Ventilator-associated pneumonia is a pulmonary parenchymal infection that occurs after 2 days of mechanical ventilation. Question. What is known about the mortality rate of ventilator-associated pneumonia? Answer. Ventilator-associated pneumonia has a high mortality rate, but it is unclear if it is an independent predictor of mortality or simply a sign of overall illness. Question. What are the typical pathogens associated with early and late onset pneumonia in ventilated patients? Answer. Early onset pneumonia is commonly linked to oropharyngeal flora, while late onset pneumonia is associated with multi-drug-resistant pathogens. Question: what are the diagnostic criteria for ventilator-associated pneumonia? Answer: the diagnostic criteria include at least 2 days of mechanical ventilation, worsening oxygenation, purulent secretions, and a positive culture. Question: what is the standard of care for preventing ventilator-associated pneumonia? Answer: prevention bundles are the standard of care for preventing ventilator-associated pneumonia. Question: what are the direct preventative measures for ventilator-associated pneumonia? Answer: direct preventative measures include head-of-bed elevation, daily sedation holidays, daily spontaneous breathing trials, oral chlorhexidine wash, and subglottic suctioning. Question: what are the indirect preventative measures for ventilator-associated pneumonia? Answer: indirect preventative measures include peptic ulcer prophylaxis and deep vein thrombosis prophylaxis. Question: what benefits are associated with the use of ventilator-associated pneumonia prevention bundles? Answer: the use of prevention bundles decreases ventilator-associated pneumonia rates, reduces mortality, and lowers hospital costs. Question: how does the duration of antibiotic therapy for ventilator-associated pneumonia compare between a 1-week course and a traditional 14-day course? Answer: a 1-week antibiotic therapy is as effective as the traditional 14-day course for treating ventilator-associated pneumonia. Central line-associated bloodstream infections. Question: what is the definition of a central line-associated bloodstream infection? Answer: a central line-associated bloodstream infection is a confirmed bloodstream infection in a patient with a central line, without another source for the infection. Question: how do central line-associated bloodstream infections typically occur? Answer: these infections occur when skin flora travel along the catheter, colonize it, and enter the bloodstream. Question: what is the mortality rate for central line-associated bloodstream infections? Answer: the mortality rate for central line-associated bloodstream infections is 15%. Question: what aseptic techniques should be used during catheter insertion to prevent infection? Answer: hand hygiene, chlorhexidine skin preparation, and sterile draping should be used during catheter insertion to prevent infection. Question: how should the catheter insertion site be selected to minimize infection risk? Answer: the site with the lowest infection risk should be chosen: femoral vein, internal jugular vein, or subclavian vein. Question: how should catheters be managed to prevent central line-associated bloodstream infections? Answer: catheter management should include the use of antibiotic-impregnated catheters, early removal of catheters, and chlorhexidine-impregnated dressings. Question: what is the recommended treatment for catheter-related infections? Answer: the recommended treatment is antibiotics and prompt removal of the catheter. Question: when is catheter salvage acceptable, and what technique is used? Answer: catheter salvage is acceptable in limited cases with restricted access sites or long-term catheters and involves the use of antimicrobial locks. Question: how is the duration of antibiotic therapy for central line-associated bloodstream infections determined? Answer: the duration of antibiotic therapy depends on the specific organism causing the infection. Catheter-associated urinary tract infection. Question: what is the definition of catheter-associated urinary tract infection? Answer: a catheter-associated urinary tract infection is a urinary tract infection in a patient with a urinary catheter or in the setting of catheterization in the prior 48 hours. Question: which nosocomial infection is the most common? Answer: catheter-associated urinary tract infection is the most common nosocomial infection. Question: what are the risk factors for catheter-associated urinary tract infection? Answer: risk factors include the duration of catheter therapy, providing a path for pathogens, bypassing urethral sphincters, eliminating protective turbulence, and causing trauma to the urothelium. Question: what methods can be used to prevent catheter-associated urinary tract infection? Answer: prevention methods include removing the catheter as soon as possible and using a septic technique during placement. Question: in which populations might intermittent catheterization be preferable to indwelling catheters? Answer: intermittent catheterization may be preferable for certain populations, such as patients with spinal cord injuries. Question: how is catheter-associated urinary tract infection diagnosed? Answer: diagnosis is made by urinalysis and urine culture, but only when the patient is symptomatic. Question: what infectious symptoms are associated with catheter-associated urinary tract infection? Answer: infectious symptoms include fever, rigors, and malaise. Question: what urinary symptoms may occur in catheter-associated urinary tract infection and why can they be difficult to assess? Answer: urinary symptoms such as dysuria and pain may occur, but can be difficult to assess in patients with catheters. Question: what are the diagnostic criteria for catheter-associated urinary tract infection according to the Infectious Diseases Society of America and the Centers for Disease Control and Prevention? Answer: diagnostic criteria include at least 10 to the power of 3 colony-forming units per milliliter by Infectious Diseases Society of America guidelines or 10 to the power of 5 colony-forming units per milliliter by Centers for Disease Control and Prevention guidelines, based on urinalysis. Question: does the presence of pyuria help distinguish between catheter-associated urinary tract infection and asymptomatic bacteriuria in catheterized patients? Answer: the presence of pyuria does not distinguish between catheter-associated urinary tract infection and asymptomatic bacteriuria in catheterized patients. Question: how does the absence of pyuria affect the likelihood of catheter-associated urinary tract infection? Answer: the absence of pyuria significantly reduces the likelihood of catheter-associated urinary tract infection. Question: what is the recommended treatment approach for catheter-associated urinary tract infection? Answer: the recommended treatment approach is removal or exchange of the urinary catheter, followed by antibiotic therapy. Question: what is the recommended duration of antibiotic therapy for catheter-associated urinary tract infection? Answer: antibiotic therapy should be given for 7 days for prompt responders and 14 days for delayed responders. Clostridioides difficile. Question: how does Clostridioides difficile cause disease in the bowel? Answer: Clostridioides difficile multiplies in the intestine when the normal microbiome is disrupted, releasing toxins that trigger inflammation and, in severe situations, form pseudomonas membranes. Question. How is Clostridioides difficile transmitted? Answer. Clostridioides difficile spreads through the fecal-oral route and is frequently transmitted by healthcare personnel in hospital environments. Question. What increases the risk of Clostridioides difficile infection? Answer. Use of antibiotics, especially during and following treatment, heightens the risk of developing Clostridioides difficile infection. Question. What are the major risk factors for Clostridioides difficile infection? Answer. Exposure to antibiotics, hospitalization, and suppression of gastric acid are principal risk factors for Clostridioides difficile infection. Question. What are the symptoms of Clostridioides difficile infection? Answer. Symptoms include watery diarrhea, which can escalate to shock, failure of multiple organs, and toxic megacolon. Question. How is Clostridioides difficile infection diagnosed? Answer. Diagnosis is made by testing a stool sample for the presence of the bacteria and its cytotoxin. Question. How is the severity of Clostridioides difficile infection classified? Answer. Clostridioides difficile infection is categorized into non-severe, severe, and fulminant levels of severity. Question. What defines non-severe disease in Clostridioides difficile infection? Answer. Non-severe disease is identified by a white blood cell count below 15,000 cells per milliliter and a creatinine level below 1.5 milligrams per deciliter. Question. What characterizes severe Clostridioides difficile infection? Answer. Severe disease is marked by a white blood cell count above 15,000 cells per milliliter and a creatinine level above 1.5 milligrams per deciliter. Question. What is the initial treatment for Clostridioides difficile infection? Answer. Initial therapy consists of oral vancomycin or fidaxomicin. Question. What treatments are recommended for severe Clostridioides difficile infection or in cases of bowel paralysis? Answer. For severe disease or when there is lack of intestinal movement, intravenous metronidazole or rectal vancomycin can be added. Question. What is the typical duration for treating Clostridioides difficile infection? Answer. Treatment usually lasts for 10 to 14 days. Question. How are recurrent episodes of Clostridioides difficile infection treated? Answer. Recurrent episodes are managed with the same antibiotics but the treatment course is extended. Question. What is the recommended approach for patients who are chronic carriers of Clostridioides difficile? Answer. Oral vancomycin is given as a preventive measure while patients are on other antibiotics. Question. What treatment is available for recurrent Clostridioides difficile disease? Answer. Fecal transplant is used to restore the colon's microbiome in cases of recurrent disease. Question. When is surgery indicated in the management of Clostridioides difficile infection? Answer. Surgical intervention is indicated in cases of peritonitis, worsening hemodynamic shock, intestinal perforation, or toxic megacolon. Question. What surgical procedures are options for treating Clostridioides difficile infection? Answer. A subtotal colectomy is the standard procedure, while a loop ileostomy with colonic lavage and antigrade vancomycin enemas is an option for select patients without perforation or peritonitis. Question. How does a delay in surgery affect outcomes for Clostridioides difficile infection when shock is present? Answer. A delay in surgical intervention in the setting of shock is associated with increased mortality. Question. What are the steps involved in the surgical procedure for Clostridioides difficile infection using loop ileostomy? Answer. The procedure includes diagnostic laparoscopy, creation of a loop ileostomy, irrigation of the colon with polyethylene glycol, and vancomycin flushes. Question. What are the benefits of the surgical procedure involving loop ileostomy with colonic lavage for Clostridioides difficile infection? Answer. This procedure reduces mortality rates and improves colonic preservation. Question. What is the history of the loop ileostomy with colonic lavage procedure for Clostridioides difficile infection? Answer. This technique was first described in a study with positive outcomes and has since been supported by smaller cohort studies. Palliative care and end-of-life question. Why is palliative care important for surgical intensivists? Answer. Palliative care is crucial for surgical intensivists because the population is aging and life-extending technologies are advancing. Question. What is the main focus of palliative care? Answer. Palliative care focuses on a patient and family-centered approach that aims to alleviate symptoms, including pain, and provide psychosocial support. Question. Why is integrating palliative care important in intensive care unit settings? Answer. Integrating palliative care is critical for providing comprehensive care in the intensive care unit. Question. Is palliative care the same as withdrawing care? Answer. No. Palliative care is not synonymous with withdrawal of care. Instead, it focuses on improving quality of life. Question. What is the benefit of early involvement of a palliative care team? Answer. Early involvement of a palliative care team, especially for elderly, frail, or comorbid patients, can provide significant benefits. Question. What is a common misconception about palliative care among surgeons? Answer. A common misconception among surgeons is that palliative care is only for end-of-life situations, which often results in delayed involvement. Question. What challenges do surgeons face in providing guidance before surgery to patients with severe surgical problems? Answer. Surgeons often struggle to provide appropriate guidance to patients with severe surgical problems during the preoperative period. Question. Can complications lead to unexpected death in the surgical intensive care unit despite improved preoperative deliberation? Answer. Yes. Complications can lead to unexpected death in the surgical intensive care unit despite efforts to improve preoperative deliberation. Question. Why is transparent communication important in cases of impending death in surgical settings? Answer. Transparent communication is important because surgeons and critical care physicians should recognize impending death and address it frankly and openly with the patient and their family. Question. What is involved in end-of-life decision-making for surgical patients? Answer. End-of-life decision-making involves difficult but necessary discussions among patients, families, and care teams to determine the best course of action. Question. Why is expert consultation recommended in palliative and end-of-life care? Answer. Engaging local experts, such as palliative care specialists and ethics committees, is highly recommended to provide guidance and support. Question. What role do critical care physicians play in palliative and end-of-life care? Answer. Critical care physicians play a crucial part in facilitating and guiding palliative and end-of-life care processes. That's it. Thanks for tuning in. If you enjoy our content, please like, share, and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.